Good morning, everybody. Welcome to our first public board meeting of 2024. I hope you all had a good rest over Christmas. So we're going to start proceedings today. Apologies for absence. I don't think I've received any apologies for absence. Is that right, Jenny?
Yes, that's correct.
Thank you. We'll move then on to declarations of interest. If there's any changes to declarations of interest, could you just let Jenny know? And if there is anything on the agenda that presents some form of conflict, if you can let me know and remove yourself for that item. Is that an issue for anybody today, looking at the agenda? No, thank you very much. We'll move then on to the minutes. Is the board happy that this is a correct record of the minutes of the last meeting? Thank you. Can I see approval for the minutes, please? Thank you very much. I'll now move on to the action log and matters arising. Anything on the action log in front of us or from the minutes that's not on the agenda that colleagues would like to raise? Looking around. Give you a bit of time. Hi, Priyanka, welcome. No, okay, thank you very much indeed. So we'll move on to our patient story today, and it's Ruby's story. And I'm going to ask Kwame, could you introduce, please?
Yeah, I'd like to introduce Sue, who would give a bit of an outline of the service, and Ruby, who would be giving us information on her journey through market weighting practice. Primary care has been part of the topical issues that we've discussed in board strategy. And we have used everything, including patient survey, walking around most of the surgeries to get triangulation about what is happening. And today's story is part of the triangulation to give us how we can improve our services and primary care offer. So thank you very much, Ruby, for agreeing to talk to us on the board. We are very keen to hear your story. Sue, do you want to start with the outline and then Ruby would come in? Thank you very much. I appreciate you coming.
No problem at all. So good morning. I'm Sue Smith. I'm the Senior Practice Manager at Market Wheaton Practice. Our practice in Market Wheaton has 9,290 registered patients, and we cover a geographical area of Market Wheaton through to the outlying villages of Middleton on the Wirral, South Cave, Seaton Ross, and everywhere in between. The practice opens every morning at 9:30 for early morning appointments with healthcare assistants and practice nurses, and we close each evening at 6 p.m. except on a Thursday evening when we offer later appointments until 8 p.m. with a GP, an advanced clinical practitioner and practice nurse. We currently have 5 salaried GPs, 2 female and 3 male, 3 advanced clinical practitioners, 2 practice nurses and 3 healthcare assistants. We also have 2 pharmacists who work in the practice. Our clinical team are supported by 13 non-clinical staff. Working in the practice, we also have a community links worker and mental health and wellbeing coach. We are part of the Harthill Primary Care Network and have the following staff who have joined our extended team. So we have a community paramedic, a clinical pharmacist, a pharmacy technician and care coordinator. We do have currently 4 volunteers who work in the practice throughout the week. So they come in and they support our patients with using the self-check-in facility. They try and help patients who are waiting in the queue to speak to one of our reception team. They also promote online services to our patients. So they're really helping us in terms of getting the word out into the community about patients, how they can access the practice, that they don't have to just use the telephone to ring at 8 o'clock in the morning to try and get an appointment. So Ruby has been one of our volunteers for a number of years now, and she's also a valued member of our patient participation group. So I'll hand you over to Ruby now, who'll tell you all about her story.
Good morning and thank you for having me. I've been a patient with Market Wheaton Practice for 14 years now, and my son was with them for 10 years. Prior to this, my mum was with the practice for 13 years, very well cared for, and always had a home visit to meet her needs. A few changes since then. I have rarely needed appointments. However, my son needed many with his many conditions. Being profoundly deaf, communication was never easy. I was his registered carer, so always in attendance to support. But with patience and respect, the staff at the surgery did a fantastic job. I have lots of lovely memories of these times. I think the first very noticeable change that caused a stir was when the practice was taken under the umbrella of the Humber Teaching NHS Foundation Trust and the retirement of long-serving staff. There were still familiar faces, and the practice, in my experience, was running smoothly until COVID arrived. A devastating time for everyone, and difficult to know where to go for help, advice, and support, especially with all the guidelines and restrictions in place. I know by experience that during the usual surgery hours, the telephone at Market Wheaton practice would be answered. The day before lockdown, my son passed away, not as a result of COVID. It was a devastating time for people everywhere. Living alone now, with all the restrictions of COVID and lockdown, and the realization I wasn't coping too well, I rang the surgery. I didn't need to explain. The receptionist was aware of my bereavement and was going to request the help of our community link worker. Within half an hour, I received a phone call. The support I was given by the community link worker was brilliant. I was supported for quite a long time, for which I was very thankful. Coming out of lockdown, all the guidelines were adhered to. It wasn't easy for the practice, and lots of bad press at times, which was totally unnecessary. But in spite of all this, all the staff stayed strong and carried on. I am a member of the Patient Participation Group, PPG for short, where patients have a voice to air their views, and representatives from the practice attend to give explanations and information where possible. It hasn't been an easy time for either. One of the issues at every meeting is the online system, as not everyone can manage this for various reasons. But there are other options and always help. I don't mind technology, but I am not a great expert. However, I do represent the PPG on a new technology the practice is piloting, named Scale, Spread and Embed. I find it interesting and can follow the information and feel comfortable to ask questions. Like I said, I am no expert, so please don't ask me to explain, but I know a man who can. I volunteer at the practice on a Monday morning, helping patients where I can, using the booking computer and directing them to where they need to be, answering questions and giving information where I am able. There have been changes in the practice, which is not well accepted, and sometimes I am able to have a sensible conversation regarding the changes. I do enjoy my volunteering. It is very rewarding and can be funny at times. I am always supported by our practice manager, Sue, and all the staff. They work as a team and make me feel part of a team. I will end my story on a high for the practice. There was an emergency in one of my shifts. It was amazing how it was dealt with, calmly and quickly. It involved a toddler. Mum came in carrying toddler and was directed to the duty doctor and a healthcare assistant. A colleague also on duty took the healthcare assistant's appointments until she was able to return. The ambulance had arrived and mum and toddler was transported off to hospital. Amazing team worked quickly and calmly. Thank you.
Thank you very much, Ruby. Really lovely to see you and meet you. It's really interesting about your sharing your story with us. What was your son's name?
Robert.
Robert.
Yes.
Our condolences for your loss of Robert, and
Yes.
and I really appreciate you sharing, you know, the support that was given to him as well, and you supporting him as his mum too. Thanks very much for that. I mean, it's interesting what you were saying about the you know, the changes and the impact of
Yes.
COVID. I'm not a technical expert either, I can assure you on that. But I'm really glad to hear. I've been to the Market Wheaton practice on a visit. I'm really glad to hear that there's this group that's involving people like yourself in the sort of technology, because I've always think that's really important, that those who are actually going to use it can feel confident about it. So having people like you there to say, I don't understand that, or that doesn't make sense to me, I think is a really important part of getting it right. Has that, you sounds like that's been helpful, and it's been, you know, helpful to involve yourself from as the patient participation group, but also as a volunteer as well. Is that right?
Yes. Oh, yes. Yes, I've been, I think I joined the trust actually as a volunteer in 2018 because I was a healthcare assistant for the trust and had a post for 7 years.
Wow.
But yes, we're working with an individual in a complex care situation. But when my son sort of became more ill, because I was his carer, then I had to leave the working side of it, but joined as a volunteer, which, you know, I really enjoy, and I love to be with Market Wheaton practice.
That's good to hear. Good to hear. Thank you. Any comments or questions from colleagues for Ruby or Sue, for that matter? Priyanka, one of our associate NEDs, there's lots of conversations in the chat box. Ruby, just to say thank you so much. Brilliant illustration on how volunteering could be part of providing healthcare. That's come from Priyanka, who's here today, and lots of other people saying thank you so much for being so open and honest about your experiences, and, you know, some of the challenges that, you know, are still there in terms of providing services through GPs. I've got Lynn who's got a hand up. Lynn, please.
Yes, thank you, Chair. Ruby, thank you so much for telling your story, and likewise, very sorry to hear about your son, Robert. It's amazing that you're continuing to volunteer for us. Thank you very much for that. Ruby, obviously you've talked about some specific examples today, and obviously we are, as Kwame said at the beginning, really focused on continuous improvement in primary care. But Ruby, is there anything else when you're out and about in those waiting rooms talking to patients that are waiting that you're hearing that we really could focus on in terms of making things better? So I don't know if there's anything topical that they've been telling you about lately that perhaps might not be in our improvement plan at the minute. So it'd just be great if there are any other examples we could pick up.
I think the main thing really is the fact that they do have to go to the A&E if there is a minor injury. We don't, and the people that always say, well, they don't like that, they're probably the patients that were with the practice when it was before it came to Humber Trust, and they, you know, I know some older people don't like change, and it's very difficult for them to accept it. But you know, what I usually do, I sit and chat to them, you know, if I can, and sort of explain things, and because the more they know about going off to A&E, or, well, Beverley or Goal it is from here usually, then they're not wasting time coming here first to have to then get themselves off to A&E.
I think that's a really good point, Ruby. It's one I'm very familiar with, and as you say, those services around urgent care and the urgent treatment centres has changed a lot over the last few years. So keeping people informed about that, I think, is critical. Let me have a think about that and how we might continue to improve that with you, Ruby. Thank you.
Yeah, we have got, haven't we, Lynn, quite a lot of other health professionals working at Market Wheaton Practice. I know I met a number of them there. So you know, people who would go and, for example, have their bloods taken for various things. There was follow up on, I think, even some physiotherapy that I met someone there, and also a pharmacist that also covers that area as well. So, you know, it's obviously GPs, but there's lots of other people at the practice as well for other sort of supports of care and health prevention.
Yeah, absolutely. And I think, Caroline, it is just making it clear to folk there is a whole raft of services now available in primary care, and a lot of that has changed over the last 5 years particularly. So raising awareness of that, I think, is absolutely key. And thank you for your support with that, Ruby, too.
Great. Stuart and then Michelle.
Morning, Ruby and Susan. I'm Stuart. I'm one of the non-executive directors of the Trust. Nice to see you this morning, and very interested in your story, Susan. Thanks for and Ruby, thanks for sharing those. You sound to me like you are a digital champion and all-round heroine, so thank you for that. Well done. And we need more of you. What would you say to someone who is considering becoming a volunteer in the Market Wheaton practice?
Join us, because it's, if you are sort of a very caring purpose, it's a wonderful thing to do. I'm very well accepted by Sue and all her staff. I've lived, I'm just trying to think, yes, my mum, she was a patient here as well. I think the thing is, it's difficult sometimes as a volunteer to explain all the changes and how beneficial it is, because Market Wheaton's grown in numbers, and I don't think the way the practice was run very, very well, and the doctors were very well thought of, and all the staff. But getting round to visit the 80-plus-year-olds on a monthly visit, I don't think that could happen now. So my mum was a patient here with the doctors, and she never visited the surgery, but that's a long time ago.
Yeah.
But yes, it's.
So your ability, it sounds like your ability to kind of translate these changes or explain these changes for others is a very important part of your role. So yeah, I really welcome that.
Yes,
thank you.
It is, yes.
Super. Keep going.
I will.
Right. Thank you. It's Michelle.
Good morning, Ruby. I think we've actually met, and obviously I've met Susan. I'm Michelle. I'm the chief executive, and thank you for sharing your very honest opinion of the practice. And as we know, primary care and GP practices is often in the press. It was again this morning with the utilisation of pharmacists, for example. So anything that we can do to help you communicate where is the best place to get advice for your particular symptoms, you were talking about minor injuries, etc., then we probably do need to do a bit more of that. And I, like Lynn, will have a conversation with you and the practice about how we can help you do that. Thank you for your service and service as a volunteer. I think, as you well know, I've mentioned many times that volunteers are crucial in the organisation. So anything that we can do to help support you, and I thank Sue for the support that you're obviously clearly given from the practice, but anything we can do to increase the numbers of volunteers at Market Wheaton, then please let us know. My question really was about, do you feel that the Trust is responsive in relationship to listening to the patient participation group, or your thoughts? I wouldn't say anxieties, but any of the issues that you've got? Are we responsive enough? Is there anything that we can improve on that, would you say? Or do you feel that through the PPG and through Sue and others that we are relatively responsive to some of the issues that are raised?
I think COVID was a very drastic thing to happen, and you know, it pulled the practice down, and it wasn't that, you know, the practice couldn't have done anymore. I think, I just don't know really. I mean, but I, as a volunteer, explain as well as I can and give out where they can get further information. So, and I do think that things are improving. I mean, I am only here on the Monday. So I've seen a difference over time in how the patients treating the staff. It is getting better, but I'm only here on a Monday, so I don't know the rest of the time. It's very. I'm a member of the PPG, but I do find I'm a Libra, so I balance the scales. So I look at both sides of the story, because Market Wheaton practice was absolutely so fantastic. I didn't really need many appointments, but my son was very ill, and they were absolutely wonderful. Absolutely wonderful. And this was a part of over the changeover of it being a partnership and going over to the trust. But the support was still there for my son, and for me, I was his unpaid carer, and the support was there. So I'm afraid I'm very protective of Market Wheaton practice, if you like.
That's fine. That's fine. And can I thank you for making a difference, because you do make a difference with the work that you do to people's lives and Market Wheaton. So thank you very much for that. And thank you for your honest conversations this morning. I found it really helpful. But thank you, Ruby, indeed, and Sue. Thank you.
Thank you.
Thank you, Ruby, very much. You'll know Marilyn Foster, who's one of our she's involved in the PPG as well. And yes, is a governor here at the trust as well, so she keeps us in touch too with what's happening as well. And you know, look, my thanks to everybody, yourself and everybody on the PPG, the patient participation group, because it's a really important part of engaging, another way to engage with patients and harness their understanding and support and listen to their views as well. So we really appreciate the group. Susan, nice to see you again. Thank you so much for introducing us to Ruby this morning, and I know you're working really hard, and there's been a lot of changes that might not be obvious to patients that's been going on behind the scenes to try and improve things. So thank you so both very much.
You're very welcome.
Take care. Have a good rest of the week.
You too. Bye-bye.
All the best.
Bye.
Bye.
Bye-bye.
Bye.
Okay, that's great. That was a really good contribution to a start of our meeting today. I think we all agreed, looking at the chat work. Lots of work been done there. Obviously, it's an ongoing situation as well, to do what we can to provide the best primary care that we can. So moving on then to my report. I mean, I know it's up on later agenda, but I was really pleased to be involved in a couple of interviews for consultants, and Dr. Saidia Alvi is going to be our perinatal consultant, and Dr. Priyanjan Udungoda, who's going to join us in the CAMS community as a community consultant there as well. I know that's mentioned in your report, I think, later on, but it was really good to start the year with those interviews and successful appointments, which was great. I also just like to mention here our thanks on behalf of the board. We've said this in other meetings, but to retiring public governors, Doff Pollard, Sue Cooper and John Cunnington, and staff governor Tom Nicklin, who wasn't re-elected, but he was a fantastic staff governor for the Council of Governors. To all four of them, they've contributed in many different ways, bringing their experience and knowledge to bear. And I think on behalf of the board, I think we'd like to thank them for their service. and I'm sure they will be involved in other ways going forward. I also just want to take this opportunity, everybody is aware of this, but to publicly just mention that it's really sad that over the Christmas period, in fact on New Year's Eve, Sam Mustafa, one of our governors, who was a lead governor as well, sadly died. It was quite unexpected. I'd had some email conversations with him shortly before Christmas and saw him at the annual members meeting. He was, you know, a really well-regarded individual, and certainly for myself personally, when I was new to the trust, he was the lead governor, and he was really helpful and supportive and thoughtful in all my conversations with him. So I know individuals who knew Sam have sent their sympathies to his family. I've been in touch with his family. Michelle, someone attended his funeral too. But maybe can we just take a moment of respect just for Sam and in honour of his service. Thank you. Okay. The rest of my report, I think, is pretty straightforward. If there's any questions, happy to take them. But a lot's been happening over the period since we last met, and there's more happening in the months ahead. So over to you. Any questions to my report? Anything? No? Okay. We'll move on to the Chief Exec's report. Just to say before we start, Michelle, just to clarify, we'll also be ratifying the procurement policy as well. It's in the report, but it's not on the front sheet. So I just wanted to flag that as well. Over to you, Michelle.
Good morning, everybody. Thanks, Chair. Thank you for that. Yes, I was going to mention that there are several policies to approve which are contained in the report. So they are there. I will take the report as read by everybody. As always, I'll pick out just a couple of areas of interest, but my direct colleagues will obviously pick out any areas that they wish to as well. It's good to actually see the visibility statements in the director's reports. I think we all know that we do get out about a lot, lots of means and methods of communication through Ask the Exec, Meet Michelle, etc. But it's really good just to give a flavour of where and it's only a flavour. There are more obviously than it's listed there across the organisation. So thank my colleagues for that. I've put a larger section in around Right Care, Right Person. This is the initiative with Homicide Police that we're a national exemplar site on. So we are getting quite a bit of media attention on that from a positive point of view. There is some negative aspects to it, which I'm working closely with the national team in Glen Murdoch particularly, but I just thought it was useful for the board to see. I did mention something about a big piece of media coming up from the ITV and BBC. We'll just pause that just for a bit at the moment, just to see how things pan out with some of the national work on that. I'm still helping the London Metropolitan Police, and we are looking at how we can solve some of the teething issues that are coming up from some of the other areas as well, and we have done that national toolkit. So I thought it was useful just to pick that out and just to remind ourselves where we're up to with that. The modern slavery statement is there at 1.2.3, which is something we have to do as an organisation. So please we'll acknowledge that and note it and approve it. It is there. Please have comments or anything, but hopefully it makes absolute sense. A couple of other things, 28 days of wellness. I hope the board are participating in that. It's something that we do every year to part of our wellbeing offer. And there's some more awards in there from people, and I congratulate those as well. I've also attached at the end of the report, I don't normally put appendices in, but I thought it was useful for the board just to have a bit of an update and reminder of some of the highlights in 2023. I know it's been a really difficult year, and we've got lots of challenges that we're working through and issues, etc., and transformation in areas and challenges which we'll see from the operational report. But it's also useful just to acknowledge some of the highlights and some of the work that has also gone on by our remarkable staff in the face of all those challenges, industrial action, increased pressure, respiratory infections, etc., that we continue to do some highlights. I thought that was useful to do. So if we could acknowledge that, please, it would be helpful. Usual operational update from Lynn. I'm sure she can expand on that. I've just picked out ESR and annual leave because it's a bit about efficiency, and I'm sure Karen may want to add about that, but we're going to start to record all annual leave on ESR. That's part of our productivity efficiency work as well. Coming back to the digital piece that we were talking about. I was going to mention the consultant appointments, but the chair has done that fantastically, much better than I could in relationship to that. But we've made some conditional appointments, which is fantastic. So I thank Kwame and the team on that. I know how difficult it is. Cyber update, let's not forget the cyber work that we're doing. Another update on RAC as well that we continue to work through, and again Pete may want to pick up that. And there's the usual communication report and Health Stars, which we're in transition at the moment to bring Health Stars, which is out of charity, back into the total operation of the organisation. And there'll be more on that, particularly at the next board meeting when we can go through some of the transactions of that. And obviously there'll be the Board of Trustees as well. I'll pause there, Chair. I'll ask my colleagues if they want to bring anything out of their report, and then I'll throw it open to questions so that if colleagues want to raise anything particular. I know Hillary's got a hand up. So I'll leave it there, Chair. Thank you.
Hilary?
Okay, thank you. Yes, I just wanted to draw the board's attention to the recent media coverage regarding the homicides in Nottingham in June last year. I would have normally put this into the CEO's report, but obviously the report had been completed by the time all the media coverage started. The homicides were, they were in Nottingham, and the perpetrator was under the care of the local mental health services. I'm sure you're all aware. First and foremost, on behalf of the board, I would like to extend our deepest sympathies to the families of Ian, Barnaby and Grace on the loss of their loved one in such a tragic way. As you'll be aware from the media coverage, Health and Social Care Secretary has ordered a review of the mental health services at the Trust by the CQC, and that review is pledging to help provide victims' families with answers. There's also an independent mental health homicide review that's underway, which is quite normal in those circumstances. They always do an independent review of the mental health for that particular individual that was in the care. By means of providing the board some reassurance of our own service in the way that we would work with affected families, 6 years ago, sadly, we had a homicide undertaken by someone in our care. We did make contact with the families, we liaised with the police and made contact with those families, and we met with them once the independent investigation was complete. That was the family's choice at that time. And that really did help us to talk through with them what had happened, but most importantly, answers their questions, which they felt that neither the independent report or our own internal report had answered for them. So it was a very difficult meeting, obviously, but it felt very helpful for the family and brought them some form of closure as much as you can in such tragic circumstances. But I just wanted to reassure the board, as we always do, once that independent investigation is complete on Nottingham Trust and the CQC review as well, we will review all the findings in there and look at our own services against those and see if there's anything, again, we need to learn from both of those reviews. Obviously, all of this will come through the Quality Committee as well, and then up to the board once we've done that.
Thanks very much, Hilary.
Thanks, Hilary. Can I just add something before we go? I know my Francis to get his hand up. One of the things that we always do from our duty of candidate anyway, but we would do anyway as an organisation, because obviously we hopefully pride ourselves on being as honest, as transparent as we get. We always make contact with the family, not just in serious incidents like this, but in general incidents, don't we, Hilary? Yes, it's a key thing for any incident that happens within our care. We will make immediate contact with the family and be guided by them how they want to be involved. That's correct, isn't it, Hilary?
It is, but obviously when there's been a homicide, we don't actually have any legitimate contact with the families of the victims. They're not known to us. We go through the police and we make that contact with them. So it's an extra bit we do, but it's the right thing to do, obviously.
Thank you very much. Are there any other members of the executive team who would like to say something before I bring in for I'll bring it in for maybe general questions, just hear from the team members? Is that okay with everybody? I can see a number of hands. I'm just thinking if we hear from the different team members. So I've got Kwame next.
And I was going to bring to the board's members, especially those who joined recently, of our fantastic research. This is the 7th year of our research conference. We've already had 250 people who have registered a conference, and all the in-person numbers have gone, but we still have people to join in online. And if you join in online, the conference will be recorded and you can also have a look at it. So please join us. We normally get a lot of support from board members who sometimes chair some of the sessions for us. And we just had our annual review of research from the CRN, and there was a lot of positive comment about how much we were punching above our weight. And all these things were reflected in our research conference. So please join us if you can. Lastly from me is that Royal College of Psychiatrics President Dr. Ladi Smith would be coming to the trust on the 12th of March in an afternoon sport to the president. So if you're around on the 12th, please come and speak to Ladi. Ladi is very fantastic, looking at bringing the college into the modern era and looking at inequality. I think our focus about right care, right person is also one of the things which is brought Ladi to us as well. So thank you very much.
Thank you. I'll just take the other EMT members, Lynn, and I've got Karen. And then I'll come to colleagues, Lynn.
Yes, thank you, Chair. Just from the operational report, obviously it does describe the 2 periods of industrial action in relation to junior doctors since the board last met. One of those periods, obviously the one in January, was 6 days. Just to really say that that obviously did test our planning again, but pleased to say that we saw very little disruption to services. So that's a good position to have been in. Our overall OPAL pressures, the obviously operating pressures, have been around that OPAL 2 position. But actually over the last couple of weeks since I wrote the report, acute pressures and ambulance pressures have been very high over the last sort of week, 10 days, particularly. Whilst we've been at OPAL 2 overall still, this has meant particularly for pressures in our North Yorkshire services. So our community services have actually been operating for the last week or more on OPAL 3. So I really just want to express that to board. No surprise really, because of the response that they're making to the acute hospital pressures. So they really are working extremely hard. They always do, in order to manage that. And I'm really pleased that they are able to flow our community beds really effectively at the moment to being able to support those discharges, particularly from Scarborough and York Hospital, where those pressures have been highest. Overall, there is some information in my report about the ED streaming service as well. Really starting to collect some really helpful data now, and that's a service obviously in HRI where we can move our mental health service users to a purposely designed environment. And what's great about that is the patient feedback is really positive. People feel safe in that environment, which is what we intended and hoped to see. But otherwise, very happy to pick up any questions. Caroline, thank you.
Thank you, Lynn. And Karen?
Thank you. Yeah, just a couple of things I wanted to point out. Michelle did reference us moving to implementing the reporting of annual leave into ESR. So just to touch upon that, that is really important for us as part of not only our digital transformation agenda and improving efficiency, but the impact on patient care. You know, ultimately, we've got quite a manual system in place at the moment, so it will support our staff to get a bit more time back. So that's a massive piece of work that's happening in the background at the moment, with a full plan to implement that from the 1st of April, which is really exciting. The other thing I wanted to touch upon, which is also in the report, which is the recruitment time to hire. And again, just from an impact on our service users and our patients, that's really important, that we know that efficient and high quality recruitment is really important in terms of getting people in and filling those vacancies that we have. And we're really pleased to be able to demonstrate a real tangible improvement in terms of our time to hire over the course of a period of time. But at the moment, in this report, we are in the top 20 out of 183 trusts for our time to hire. So just wanted to draw that to your attention. And then finally, the last thing is just a bit of information that I did pop into the report quite late in the day, but we're actually second in the country at the moment for the percentage of staff accessing training, which I'm incredibly proud of. And I know a lot of work has gone into that. It is fantastic. We are we have very high compliance rates with statutory and mandatory training, and I do think all of the efforts are really paying off in terms of particularly that statistic, which, like I say, is great. It's great for the trust, and I think it's fantastic. Thank you.
Karen, is that across all NHS trusts? We're second in the country.
Yeah.
I wasn't sure whether it was our mental health trust, but that's across every single NHS. That's amazing. Yeah. That's brilliant. That's really good to hear. Thank you for that. And just to say, Pete's put in the chat box that to confirm that rigorous review has been undertaken, and we have no reinforced aerated autoclave concrete on any of the builds on our estate, which we'll all be reassured to hear. Right. Okay. Francis, and then Priyanka, and then I've got Mike, and then I've got Phil. Francis.
Thanks, Chair. As ever, really comprehensive report. So thanks to the team. and I was going to pick out a few things that I thought were great. Karen's picked out a few of them in terms of recruitment, etc. And the right care, right person is fantastic, as was Stephanie Atkinson getting to the unsung hero. I think that's really impressive. Just a couple of quick questions or expansions which might help people. I just wondered, there's been a lot of coverage about Huth and their emergency department and the pressure they're under. I just wondered if Lynn could expand on that and the impact it is maybe having on us. And then for Hilary, we've obviously heard about Market Wheaton today, and they've had the CQC inspection. It might be helpful just to expand on what happened there and why requires improvement on one, but we're good still overall. It might just be helpful for people to understand that. And then just a question about the nurse recruitment, which looks great, but is the target a net target? Or so are they looking to recruit 50,000 nurses net of anybody leaving, or are they just looking to recruit 50,000? So just trying to understand that. So one to Lynn and two to Hilary, please.
Thank you, Francis. Lynn?
Yes, Francis, obviously those pressures in HRI's ED are a focus on daily system calls that we have with our system partners. So we absolutely do everything that we can in order to support those pressures. I'm pleased to say, obviously, we have a mental health liaison team in situ in the ED in HRI. The KPI that they work towards is a 1 hour response to any referral that they receive from ED, and we meet that KPI, which is great. Obviously, with the opening of the ED streaming service, the Humber Suite, as it's called, in ED, we are in a position, obviously, of the referrals that we get, we are streaming about 40% of those to the new suite. At the moment, and obviously that therefore alleviates some of the pressure, creates more space in the main ED for them to manage patients. I said in the report, obviously the service opened in June. We still think there's more capacity in that streaming service to stream more patients. So we meet very often with our colleagues in Huft to pursue plans in order to improve that even further. Hope that answers your question, Francis.
That's great. Thanks, Lynn. Yeah.
Market Wheaton, who's going to take that up?
Market Wheaton, yes, I'll take that. Hilary? So the last time Market Wheaton were inspected fully by the CQC was 2019, and they were good across all of the 5 key lines of inquiry. This was quite, in terms of comparing it, quite a light touch. It was all done on Teams, and it was information that was sent in, and they were only looking at the responsive elements. In looking at the responsive element, they could see all of the good work that the practice is doing. And obviously, we've just had that fantastic story from Ruby, haven't we, and how she's supporting access, which they took all that on board, but they were looking very much still at the feedback, which was through the GP survey from last year, which is, well, we know because we've seen it at the board, the low response to that, the poor response around access. So they've obviously made a decision on the back of that it would have to be requires improvement until they got feedback from service users around improvement around the access there. So that's why that one came as RI. So you can get an area that's RI, but then be good overall. And we're a point in question. We've got RI, haven't we, for safe, but we are good overall. So that's Market Wheaton. Is that okay, Francis?
That's great, thanks. Yeah.
And on the international nurses, that's a very good question, Francis. My understanding is it is 50,000 more nurses on the NMC register. So that does not mean that they're in work necessarily, but they're on the register, and that's the way that that's being counted, is my understanding.
Okay.
I must say, I was very surprised to see how many were overseas. I think everybody was, and that was 93%, wasn't it?
Yeah.
Yeah. Massive.
Okay, thanks. Thanks, Chair.
Interesting that, isn't it? Because, you know, when that's reported in the media, I think public might see that, or politicians might use that number, and, you know, if people might take away from that something that is different to what is actually happening in reality.
I think if you've taken the time to come across here from overseas and be registered, you probably are working. But whether or not you're working in the NHS is another matter, isn't it?
Yeah. And whether we've lost 20,000 at the same time is
Exactly. Okay, right. I've got Priyanka.
Thank you, Chair. My question is for Hilary. It's maybe that I don't know about it and the others do, but I just wanted you were talking about the homicide case and when how the trust provides support in instances to families. So my question is it do you have like one particular committee that does it, or according to what the case needs, do you get specialized teams to support each case as it comes along?
Within our patient safety team, we have nominated people to work with the family. We have a nominated contact point, and that person then signposts to the relevant person. Obviously, myself and my deputy oversee all of it to make sure that the signposting is correct and that the right people are getting involved. So particularly with the homicide, that was then obviously trying to find out beforehand from the families affected what they wanted to know from us, what sort of questions they wanted to ask, that we made sure that the right people at the right seniority met with that family, and that those staff members were supported as well through that process.
Thank you. Mike and then Phil.
Thank you. Question for Lynn on the Humber Suite at Humber Royal. Excellent news conceptually. I just wondered, first of all, whether it's classified as a place of safety under Section 136, and in any case, how does it interact with our 136 suite?
Thank you, Mike. It's not classified as a health-based place of safety. Our health-based place of safety remains at Miranda House, obviously, which is on the HRI site overall. And through the liaison team, Mike, as you would expect, those connections between liaison team, the crisis team, and the team that obviously support anybody detained under 136 are really close. Those services are actually managed under the same manager. So obviously the clinical pathways are constantly reviewed to make sure that they are as effective as they can be. So and you know, but by and large, you know, that sort of model and way of working works very well. We're very proud of that model, Mike. The ED streaming, as Michelle said in the chat, is also, you know, quite an innovative model. So we'll continue to evaluate that. I'm sure we'll continue to make improvements over the next year or so. One area that we are looking at the minute is the relationship between the suite and children's services per se. So obviously there are quite a large number of children with mental health needs who present in ED as well. So we really want to make sure that it really is an across the age range service as well. So that's really where our focus is right now. But that health-based place of safety pathway works well, and we continue to liaise with colleagues in HRI around that too, as you would expect.
Thank you, Lynn.
Thank you, Mike. Thank you, Lynn. Phil.
Yeah, thanks very much, Lynn. I was going to ask a bit more, if you could have a bit more information about the Humber Suite, but we've heard quite a bit. It'd be really nice, maybe a few months down the line, to understand how that's working and to get a more sense of how it's working, because it's a really interesting development, and it's an acute A&E these days is not somewhere to be if you're emotionally or mentally distressed. Yeah. So I really welcome that. And then just with NHS talking therapies, I noted, and this has been you see it a lot, is that the dropout rate when people are referred. And I just wondered, a few years ago, we took what we thought was quite a brave change in Wakefield, where we let the patients refer themselves. and I just wondered whether that was happening locally, because that seems to have sorted out that dropout rate and has been a wholly positive change. So I just wondered what happens locally.
Yeah, so we provide the service in East Riding, Philip, and yes, service users, patients can self-refer.
Lovely. Then the last thing obviously was just the requires improvement from Market Wheaton. It's just a little bit worrying that now, no matter how much improvement you can prove on an input, that they're just taking hard survey data, because obviously the GP patient survey data usually reflects patients' attitudes over the last 2 or 3 years. So there's, no matter how hard you're working, there's always going to be a lag. That feels a little bit disappointing for surgeries.
I agree.
I have fed that back in, Philip, because it's happened with a couple of our practices, and I think you're right. I think to look at the totality of everything, so the action plan and all the other things were absolutely great, and the work that the staff are doing, and the demand on the service as well. And the survey results are quite limited to numbers of people. I'm not saying it's not there. We do actually take a long time, the executive management team speaking about the surveys, etc., etc. But I do think it's that totality of the inspection or the review of the services, or however we want to call it. So I have fed that into the CQC, but we'll wait and see if that's helpful or not.
Because in the past, the inspectors would look whether the practice has got insight into the problem, so that they recognised it and they were actually doing something about it. And that if that had been that process, so they recognised they've got an issue, they've done something about it, and it seemed to be starting to make a difference, that they would have accepted that as a sign that this was a good practice. So that was a bit disappointing for me, but don't let the practice get down about it, because they're overall good still.
No, we're not. And I think through the quality committee, Philip, you'll see that the full report, and they actually acknowledge that they acknowledge that we're doing a lot of work in relationship to communication, engagement, etc., etc., etc. So they actually acknowledge that in the actual body of the report, but you'll see that through the quality committee.
Good. I look forward to seeing that. Thanks,
Phil. Thanks very much. David, and then Stuart.
Thank you, Chair. Lynn, a question about the Humber Suite. It's a 3-point question, really, and it's about the staffing. And is this a new team, or is it a redeployed team? Has it had an impact elsewhere? And kind of how resilient is that staff team? Because it's not easy to find new additional staff right now.
Yes, David, obviously that was something that we worked hard about before we opened the service. To answer your question, is it brand new or is it a redirection? It's a bit of both, David. So we have expanded the team, but obviously it is an extension of the existing mental health liaison service that I provide. They would otherwise have seen those patients obviously in the main ED. They're now able to see them in a dedicated suite. But we did increase some elements of the workforce, particularly those STR workers, sports time recovery workers, because what's making a real difference, obviously there is always going to be a wait, hopefully no longer than an hour. But in that time, there are support workers in the vicinity to receive service users and really welcome them into the suite. And they actually do an amazing job. By the time they're assessed by the registered clinical staff, they're already orientated to where they are. They've already been provided some support. So that element of the service, and we're able to do that in a space that feels safe to people, is making such a big difference.
That's great. Thank you, Lynn.
Okay. Thank you, Stuart.
Yeah, thanks very much. This is a really interesting report, and the whole is giving rise to lots of questions, isn't it? My question is about digital. And Karen, you said that the switch to I'm never sure it's digitization or digitalization of annual leave. In most organisations, that would be regarded as a pretty standard. So my question is, where, and maybe not for answering today, but to think about, where are we picking up the next round of innovations in the, if you like, the internal efficiency of the trust's operations? Is that covered under the Be Digital work? And where might we see the outcome of that work? Pete, I guess this might be for you, and I can see your hands gone up anyway.
Yeah, I think it covers in 2 areas, Stuart. It'll be picked up as part of service planning. So as part of the service planning round, we're looking at where digital innovation or transformation can improve. But equally, that would then feed into the digital groups we've got in the group. So we've got the digital and data group, where we consider new applications for digital funding on an annual operational basis, I'll say. But at the big digital board, we'll probably be looking at the bigger digital transformation pieces that have come out of the service planning round and the planning guidance and anything that's coming out at the time.
Yeah, and it's probably a bit of intel to pick up from staff where they feel their kind of things feel like very slow and cumbersome and kind of just taking too much of their time as a pointer to where to go next. But yeah, thanks for that, and so I'm assured it's being picked up in the service planning and Be Digital. Thank you.
Thank you, Stuart, for that. I can't see that was a really good range of questions. In fact, some of us met with Hilary was there as well, met with some newly qualified staff in the unplanned care division, and actually the Humber Centre came up there as well. I think it was Paul Johnson who said that actually one of the really good things about it, and board may recall that we invested some resources to actually create the space as well. That has been a difference from having something that is a fit for purpose space that isn't, in the bowels of the earth of the hospital. It's actually nearby and is a good place for both the staff and the patients to be. So it was really good to hear some of the staff, newly qualified staff, were talking about that yesterday when we met them. So yeah, all good. And Michelle, what if you just put something in the chat box there before we end here? So yeah, just something about this, the survey and how it might be worded. And I know that you're sharing, aren't you, Michelle? You've sent a briefing already to the region around the patients, the streaming at Huff as well, which is good to hear, sharing good practice.
And I'll send it around here. I'll send around the board as well.
Brilliant.
So the board have got sight of it as well.
Yeah, great. And there was in the chat box, Kwame, people were really interested in the visit you mentioned earlier, and I think David had some experience of work. Is it Lade? Is that have I pronounced that right? Thank you. And it'd be great if you could just maybe share that via Jenny to the board, and we'll see who might be available, not to overcrowd the person when they arrive, but it might be appropriate for some of us to meet on that day as well, on the 12th of March. Brilliant. Thank you very much, everybody. Now let's get back to the agenda. Publications.
Sorry, Chair.
Sorry. We have to approve the modern slavery statement. Can we see all those in favour of that, please? Approval for that. And can we ratify procurement policy, volunteer recruitment policy, learning and staff development policy, please? Thank you very much. Thank you very much. Right, okay. We will move on to the publications and highlights report. Michelle.
Yes, thank you, Chair. Usual report, picking out some of the national reports that we don't cover directly in the Chief Exec report or elsewhere. The relevant director that is leading that particular report has put a little bit of a narrative in there to how we're going to take some of the issues forward. It's just there for comment or information or anything anybody wants to pick up, Caroline. Thank you, Chair.
Thanks very much. And it's really helpful having the comments from EMT members under it as well. I found that really, really useful. Any comments? No? Okay. Thank you very much. And we will move on. And I think we have Sarah with us today for item number 9, which is social values report. Kwame, do you want to say anything before Sarah presents?
Yes, thank you very much, Caroline. Sarah is here. Social value report, for those of you who are new to the board, is something that is dear to the heart of the board. We are very proud that as an anchor organization, we do, in spite of all the demands on our services, provide input into the society, both economic and health, beyond what is required of us statutorily as a health organization. And the staff are really, I'm always very impressed about how much they want to bring their stories to make this report, bring the report alive, and also their energy to provide input into the community. So Sarah would expand on some of those, but the report is also there. I think we do have a few hard copies for people to read as well. So Sarah, do you want to?
Thanks, Kwame.
Thank you for coming.
So as Kwame summarises, this report's really about our wider impact on the communities that we serve over and above our core purpose. And the report really tries to set out the social value that we deliver, and that might be in terms of supporting the local economy, providing local jobs and helping people into employment, supporting the well-being of people within our communities, and also things like environmental sustainability, which really align with anchor values as well. So our role as an anchor organisation is embodied within this report. And it really shows the commitment, our commitment as an organisation to the communities where our staff, patients, service users, carers and families live and work. We've structured the report against the strategy goals, which I think is a really good way of showing the breadth of work that we've undertaken. It also shows that although we've got communities, people and social values as a specific strategy goal, our social values impact is a golden thread that runs across the work of the organisation. Within this report, where possible, we've included some statistics which quantify the impact of our work. And this is all specifically about the Trust's impact and what we deliver, trying to quantify that. In addition to covering a really broad range of our strategic goals, the document also shows how our social values work is spread across our organisation. So within the report, you'll see examples such as from our corporate teams, championing volunteering or investing in electric vehicles. And we've also got examples from across our clinical teams, going over and above to improve access to perinatal mental health services. We've got something about peer support workers being employed in our forensics teams, as well as our support for experts by experience, or doing things like supporting Hull City Council to improve access to museums for people with additional needs. So I hope the report is well received. I think it shows a real breadth of activity. And it's also been really great to see how proactive our staff are, not just in undertaking this work, but in coming forward and sharing these stories with us.
Okay, thank you very much, Sarah. There's a few points in the chat box which colleagues might ask something about. I'll start with Mike and then Stuart.
Thank you, Sarah. I think you're absolutely right with the golden thread, but can I start with saying what an excellent read it was? It's not only the content of it, but visually, I was left with a warm glow when I finished it. The most fantastic photograph of Michelle and Kwame. I loved that photograph. That was really great. But back to the golden thread. One of the things that's a bit connected to the people strategy, I think, is that we're particularly explicit about upskilling. And what I'm thinking of is governments often talk about numbers of jobs created and so on and so forth, but we're in a market with the training that we do where hopefully we'll see healthcare assistants becoming nurses and becoming executive directors of nurses eventually. And I just wondered whether we measured progression in our organisation and how much we add to individuals' economy, moving them into higher rates of pay and so on and so forth. Hope that all makes sense, and I think it is connected to people strategy as well.
It's a really good idea, actually, and a good point there, Mike. Sarah?
We haven't looked at that specifically for the social values work, but I don't know whether that's something we want to pick up separately with Karen as to where that sits in terms of OD and looking at how people progress within the organisation.
Yeah, it'll come up later in the agenda. Yeah, thank you.
Okay, thank you, Mike. Sorry, Stuart.
Thank you. Hi, Sarah. Really good. I really enjoyed reading this report. And what's the status of it? Is it kind of published yet, or is there another round of possible improvements to it?
I think it's due to be published after this meeting, so this is the final approval.
So I mean, I think it's good quality stuff. I think a couple of things that I would just think we could make more of maybe in the next iteration, so next year. I think on the sustainability, efficient organisation bit, I think we could do more about the physical the consumption of physical goods, not just carbon footprint. So waste and other kind of things that the organisation consumes in its delivery. We could do that. That would be fairly standard environmental type reporting we could add in. And then I think the other kind of overriding observation is that the percentage rises are really good, but I think we could do on occasion with more of the absolute numbers. So a 70% rise in something, is it a small number or a large number in quantum terms would be good. And then I think we should increasingly move towards having some explanation of where some of the metrics come from, particularly the the measures of added economic value and so forth, because there can be a bit of an art and a science around what these really mean and where they come from. And I think having just a really simple appendix of this is how we measured it, and the methodology is useful to give it some perhaps a little bit more credibility. And then the other thing we could make more of is the local supply chain. So we talk about how much is spent locally, and there's some really great examples of how suppliers demonstrated added value, and the 10% of social value mark they get for procurement. But some more information about kind of what kind of companies that we do business with, as opposed to where we contract nationally, I think would give it a little bit more of a kind of local flavour. But on the whole, it was well presented. It was very well written, and like others, I like the balance of the visual and the words. So well done, thank you.
Thank you. We have kept a record of the methodology that we've used, and kept a record of that year on year for some of the statistics. So yeah, it is there, and we could include it. That's
good, because I think over time, I think sustainability reported, social value reporting will be increasingly subject to scrutiny as organisations have to really demonstrate they're not, making it up, greenwashing or whatever you want to call it. So good, thank you.
Thanks very much, David.
Thank you. I guess to echo what others have said, I mean, this is an absolutely superb report. It pushes all my buttons, and I've done a lot of work around social value over the years, and I've worked with a lot of organisations that have spent an awful lot of money on producing reports, and this knocks the socks off them. Honestly, this is phenomenal work. My question, however, is how are we going to disseminate this? Because it's a superb report, absolutely is. But what's the plan for getting it out there? And then how do we know that plan has been successful? So it's great to hear that it's going to be primarily digital. So does that mean we can track the downloads and track where it's gone to? Because if we have a fantastic report that only we see, I think we're missing a real opportunity.
Thank you, David. Sarah?
I'm hoping to defer to my colleague in comms here.
Rachel there?
Is James from comms here? Is that who's representing comms?
He is there, but he might not have the full data on that. I'm speaking to Rachel tomorrow. So once this is approved, I think what we need to do, I think David's absolutely right. And thank you for that feedback, David. We'll get a full comms plan sent out and put together. And so we do disseminate it widely, because I think you're right. Obviously, the iterations have improved over the last few years, and I thank comms for that, because I really do like the visibility of it. But you're right, David. I think before we've just probably had it a little bit too digital, and I think we need to get that mixture really, and almost have a bit of a launch to actually, shout it from the rooftops anyway. So we'll do that, and I'll feed back to the board.
Yeah, I think that sort of in the chat box earlier, I thought everyone was really impressed with the highlights of 2023, but again, I think it was Francis' comment there in the chat box about how do we get this information out? And I mean, we're not short of information, that's for sure, and good information, I suppose, is how you can find different ways to get to people. And maybe part of that, Michelle, is also there might be certain bits of this to select rather than the whole thing, that on postcards or whatever it might be, in different ways that might be more pertinent for different communities who might have an into interest in this. But it's really good, and I think all the points raised today, Sarah, are sort of icing on the cake, if I can pick a phrase, really. It was really very good and very impressive. And I think I'm right in saying, thank you about the photograph of Michelle and Kwame. I think I recognise those photos. I don't think you were actually standing together when that photo was taken. Am I right? I think there's been the marvels of photography science has played a role there, but in their own right, individual portraits are lovely, and they come together in a very complimentary way, I have to say. Okay, right. Thanks very much, Sarah. We are here to approve this today. So all those in favour of approving this report. Great. Thank you so much. Thanks very much, Sarah. And we move on to the people strategy. Karen.
Thank you. So I am really pleased to be able to present to you today the people strategy. It has been a bit of a labour of love amongst quite a few of us. So I'm really glad to see it here at this point. And I know a number of you have already seen it through various committees and at various stages in the sort of course of its development. The people strategy has been drafted to align drafted to align to the trust strategy quite closely and the regional and national people agenda. And as we actually began the kind of draft of this, the long-term workforce plan did land as well. So you'll see that that's kind of encompassed within there. We did navigate a full programme of co-production, so I'm really pleased again to be able to say that we've got the co-production stamp on there. That did include a session with some service users and carers as part of our PACE forum, which was really important to us in terms of the development of the strategy and making sure that it met the needs not only of our workforce but those receiving care and accessing our services. And again, the strategy was co-produced across a number of sessions. So we did hold organisation-wide sessions that were open to all staff, as well as some more bespoke and targeted sessions, particularly around our sort of TCNC, our professional needs, etc., etc. So it's really been through the ring, this strategy, to get to this point. What you'll see within it is 4 specific strategic goal areas. And I will point out at this stage, because it's something that's come up a few times, is that we don't have a specific goal related to retention. What we felt as we developed the strategy was that actually retention is the golden thread that goes through all of the goal areas. So whether it's attracting people, culture, wellbeing and inclusivity, innovation, etc., etc., it's all of those contribute to our retention agenda. So that has been sort of mentioned within the strategy, just to draw out that it is an important element that's kind of is interwoven throughout. So I will stop there. I'm happy to take any questions, but this is for ratification today.
Thanks very much, Karen. I think another excellent report and really readable. And I have to say, I love the final section, which is measuring success, because I know colleagues on the board, when we were going through the strategy refresh, in terms of that document, we're really interested to see about, what will change, but how would we measure it and what would that look like? So I thought that was really helpful there, and a very good example to others who are thinking about how they look at our strategic objectives and how it would be measured. Lots of hands. I've got Francis, then I've got Stuart, Mike, Dean and David. Francis.
Thanks, Chair. As you said, I'll reiterate, really excellent piece of work, really flows well, really easy read. My questions are around, on a really practical basis, how do we now link and influence back up into the ICS? How do we communicate it externally so people know what we're about? And how do we link back down into the organisation, showing the team how it's going to positively impact on them? So it's a great piece of work. It's now the practicalities of influencing up, influencing down and influencing out that I was kind of interested in.
Thanks, Francis. Karen?
Yeah, no, that's really, really key. And I think from an internal perspective, so we've got a full comms plan, and I had hoped to be able to play a video today, but it's not quite finished. And I have had a camera in my face over this, reluctantly, I will say. So in terms of that communication in the organisation, absolutely, we've got a full plan to roll that out, and ultimately it will be fed into the business via those partnership roles, via the HR business partners, through the ODG, again, who have been have influenced the strategy as well. In terms of our external links, obviously I will be pushing it out there. I know others are, in terms of through my links through the HRD network and through our ICB partners and things like that. And we have linked this strategy to the ICB strategy as well, quite strongly at the beginning there as well, Francis. So we will be sharing that with our partners as appropriate. And the other thing that I didn't mention was that, and particularly on the point that you made about measuring success, Caroline, is that we do have a people strategy delivery plan that sits behind this. So a number of actions with timescales across a period of time to actually meet the demands and the objectives set within this.
Thanks very much, Karen. Okay, Francis. Mike. Oh, sorry, Stuart, and then Mike.
Thank you, Karen. Yeah, really good stuff. This just a couple of minor comments, really. One is there's a reference to being a cog in a machine. Is that slightly pejorative these days? That feels quite Kafka-esque to me, and I wonder if there's a different phrase, like part of the team, whatever. But if people aren't jarred by that, I'm happy with it.
I'm open to comments on that. Like I mean, it's not come up with a comment before.
It might be a kind of a vox pop thing. On the measurements, what that table brings out for me is that it's actually attracting unbelievable people, goal one, that seems that's where I feel we're probably furthest away from the aspiration, from the target. So that feels to me, it just reinforces the focus is on attracting people. I got the impression. It'd be interesting your view on that. And you mentioned just now about kind of retention being the golden thread. Yes, I agree. But there's also a balance between innovation and retention. So bringing new people in can sometimes be a gear for innovation. That's one thing. I'd be interested in your view on that. And then there's a really, really detailed point, which is, the percentage of LGBTQ plus staff. There's a reference on that page. It's actually 22 of your document to the ONS data on the proportion of the total population as being 2.4, because I'm interested in these things. The ONS has a latest statistic for 2022, which is actually 3.3%. It's a minor detail, but actually these things, if we've got a later set of data for the ONS, it might be worth just referring on that.
Yeah, so if there's some later data, we can absolutely feed that in.
And I'll mail you just to confirm that. I found it. Yes, I was really interested in that proportion. Okay.
Yeah, no, I appreciate that. So going to the outcome measures, yeah, absolutely. In terms of attracting people, obviously we will see that resonate through reducing our vacancy rates across various hard to recruit roles. And I don't dispute what you're saying there, Stuart. I think you're right. It is probably one of the hardest things that we need to tackle in terms of bringing people in. Although I think we can probably say, particularly around nursing, we're already seeing a bit of a dent in that already. Our nursing vacancy rate is well below 10%, obviously much below the 2023 baseline that we reported in there. So we're already showing progress. And I think the actions we have in place are to support and underpin making that progress with the strategy. Like I say, but it is going to continue to be a challenge. And I think it's influenced by a number of factors, isn't it? So we've tried to be quite measured in terms of the goals that we're setting ourselves so that they are as achievable as they can be. But we do appreciate that, like I say, there are external factors that are going to influence this.
Thank you.
Thank you, Stuart. Mike and then Dean.
Thank you, Chair. Thank you, Karen. Another excellent report. And these things are always teamwork, and it will have been very difficult in its birth, so to speak. But compliments to the design work that's gone into this. It's really, really excellent. But just linked to what I was asking Lynn about, and also to these things that Stuart said about Unbelievable. We do want to recruit unbelievable people, and we are sometimes challenged with that, with our location and so on. But, we will build our image and we will do that. But where we can't recruit unbelievable people, could we have an aspiration to make our people unbelievable? Because we've got very high levels of training and so on. And back to the progression, the culture starts from the top. And I think that the culture we get from our chief executive and team and chair, and hopefully the board, is one of the best cultures that I've ever come across. So, I'm just planting a seed really, and wondering whether we can aspire to make all of us unbelievable.
Yeah, I think it's a really good comment. And I think what I can say is wholeheartedly is the Trust is committed to developing its internal people. We've got a programme of work to bring people through their careers, through degree nurse apprenticeships, for instance. We have a number of people going through those at the minute. We've got an apprenticeships and a career development team who are focused on developing the people within our services and our teams to see them develop through their careers. We have a number of pathway apprenticeships that can see people move from coming into the organisation, whether it's from finishing their studies, their A-levels, whatever it may be, and coming in and actually moving through a full career pathway from a level 3 all the way up to a level 7. And we have ambitions to see that realised. And it's certainly, we're starting to see the fruits of that. We've got people in HR, particularly as an example, who have come in and done a level 3 qualification, are already now doing a level 5 with ambitions to do the 7. So we're seeing that really start to play out. And it really is an ambition of the organisation to see more of that and to grow our people.
Thank you, Karen. Excellent.
Thanks, Mike. Dean?
Thanks very much, Caroline, and thanks, Karen. Just a bit of perspective just from the workforce committee. colleagues will recall that I guess this had its origins in a timeout that we did as a board a number of months back, and highlighting there that need for sort of engagement. And I think Karen, as she said, in terms of that labour of love, really developed it from that initial sort of bit of presentation that we had there. And you'll see in the paper all the sorts of various engagement initiatives that are being on. I just thought it was worth sort of highlighting that in terms of all the work we've been doing on staff engagement, and making this something more than it's just a document that we need to have, into something that people can sort of own and appreciate and feel part of, coming through. So well done around all the engagement on that. And given the updates that we've had at the Workforce Committee throughout, Karen, that labour of love certainly comes through on there. And then it's just picking up Stuart's point, Francis' point about the ICB, really. There are a lot of things, particularly in terms of pipeline, that we're dependent upon people doing that are beyond our organisation, in terms of, people into medical school and nursing schools and AHPs, etc., that create that. And I know that the ICB will be working on HITS plans around the long-term NHS workforce plan, and I know that we'll play our part in that. So it's great that we're in a position in terms of knowing what we want, and knowing how we want to get there with those outcome measurements that can feed into that. So I think it should hopefully complement the work that will be going on at that sort of ICB and regional level as well. But it's just well done to Karen and team, I think, to get it to this, and we've given it a good knock around over the last year.
Thanks, Dean.
Yeah, thanks, Dean. Thanks for the work of the Workforce and Organisation Development Committee as well, in terms of their oversight on this. David?
Thanks, Karen. This is a superb read. To echo Mike's point, another superb report. And we've got some talented people in marketing, haven't we, that can kind of give them the look that they have, that consistent look across the trust. My question really is around, this might be because I'm still new to the board, but the previous strategy. The new strategy is ambitious. It's got a lot of exciting stuff in there. And I'm just curious about how did we evaluate the effectiveness of the old strategy and where the learning came from that, so that we're not setting off with any new ambitions that we weren't able to deliver for X, Y, and Z reason in the previous strategy.
Just what I would say is that obviously any outcomes and targets and measures would have fed in through the Workforce and OD Committee. So we, as I think you saw at the last meeting, actually, we populate a People Insight report which shows and demonstrates our progress across a number of various metrics. So we always did have a workforce sort of people delivery plan in the background behind that strategy as well, that saw our progress. And we're pretty good, like I say, within the People Insight report at demonstrating progress against those areas. And some of these measures, David, they will follow through because they are relatively standard, when we're looking at particularly vacancies and turnover and things like that. So they're really kind of transferable measures across that strategy and then into this one.
Okay, thank you. And Priyanka.
My question also stems from one of the questions David asked first regarding the first report, but now considering the first report and Karen's report, and how and Caroline said about how we can use them to be passed on. But as we all know, we get a lot of information, proper information overload all the time. And do you, when you are either to the public or to the staff, when you are trying to give the information from your report, is there any possibility of using sort of a targeted approach rather than giving all the information to everybody? And because then there would be more take up or more interest to have a look at things. So maybe, I don't know, you may be already doing that, but maybe as I'm new that I don't know about it, but I'd like to hear if you can.
Yes,
thank you, Priyanka.
Yeah, thank you, Priyanka. It's a good question. And I think what I'll say is that whilst obviously some of the committees will get a full report of our progress against a number of metrics, when we're showing progress out in the organisation, it is often in bite-sized messaging. It might be through Ask the Exec, where we're sharing news that we've, met a certain target or achieved something specific within the strategy. So it wouldn't necessarily go out into the business and out into the community in terms of a full report into where we're going. It would a point in time in terms of progress, but it would be that those good news stories or the areas that we're focusing on. So we would share it in that way, I would say. Does that answer your question?
What I also wanted to know was, say if you are, say for instance, if you are doing trying to promote some sort of staff training, do you target it to a certain type of people, or is it just put out there for anybody who likes it to take it on? That's what I wanted to ask from you.
Yeah, so training is a good example. So we have role-specific training. So if we're promoting mandatory training, we will do that to a specific group of people. Ultimately, if there's something that should be or could be accessible to all staff, then we would advertise that. So what we do, and we work with our comms team really closely, we look at the most appropriate kind of mechanisms to get the message out to the right people.
Okay.
Thank you.
Thanks, Priyanka. Michelle.
Yeah, thank you. Thank you for the great comments, and thanks, Karen, the team, and everybody for the work. Because as people have said, it's been a collective team effort, and including staff, because obviously there's been staff consultations on it as well. Just for our newer members, really, just to and thanks, David, for the comments about the communication and marketing team. I will feel that back because it's quite a small team. And we don't spend a lot of money on things that you mentioned, the social values report and this, other organisations would. So we do that in-house in the main. So thank you for that. I will pass that back on. But just for the new members, this is our enabling strategy. So we've got our overall trust strategy. Apologies if you know this already, but we've got our overall trust strategy, which is the main key element of it's the main element of everything that we do. We've got to call certain things strategies. So when we're inspected, we have to tick them off. But this is a core strategy that feeds into our overall strategic goals. And obviously, we've got 2 strategic goals around people, etc., etc. So this is our one of the main enabling strategies. Just thought to clarify that, and that's why everything should look very similar to everybody else. But it's all part of our culture and our developing our community. So thank you, Chair. Thanks, everybody. Great work.
Thanks, Michelle, for clarifying that. That's all roads lead to Rome, as I say, to the overarching strategy in different ways. It's just about breaking it down, isn't it, and having that focus in certain areas. Great, lovely. So Karen, thank you very much. Board, we are asked to well actually it says, are we approving or ratifying? It says approve on the agenda. Oh no, ratify this one. We're being asked to ratify this item and this report. All those in favour of doing that? Great, thank you very much indeed. And we will move on now. Kate, thank you for your patience. We're running a bit over. There's lots of interest, obviously, in the earlier reports, and I know there'll be interest in yours as well. Hilary, did you want to just say something before we hand over to Kate?
Yes, thank you, Chair. Just so this is the further work that we've done on signing up to the Charter, which we did last September around sexual safety. This is for staff. So it's our workforce, this focuses around these pledges. But I've also asked Kate just to give a bit of reassurance to the board around some recent media coverage around sexual safety in patients, for patients as well. So Kate will obviously present this, but also give some reassurance to the board, hopefully, on what we do around that as well. So over to Kate.
Thanks, Hilary.
Morning, and thank you for inviting me to the meeting this morning. So I'm here to present the Sexual Safety Action Plan for approval. This plan has been developed in consultation with Workforce and OD and in consultation with staff across the Trust as well. The action plan is based on the self-assessment that was undertaken against the 10 pledges in the NHS Sexual Safety Charter that the Trust signed up to in September 23, and also some national publications around sexual safety within the NHS. It reflects the work done over the last 4 years by the Trust, and the self-assessment does provide a significant level of assurance in respect of how we meet the 10 pledges already. However, as a learning organisation, we have identified some further areas where we want to further strengthen our arrangements. The work dovetails and aligns with the Respect campaign and the Humber Behavioural Framework, and the Sexual Safety Steering Group has been established to take forward this action plan on behalf of the board, and it will be chaired, it's co-chaired by Workforce and OD and our Head of Safeguarding. There will be a 6-monthly progress report to EMT that's proposed, and reports to the Safeguarding Learning Forum and to QPAS on our progress. Just wanted to comment or provide some assurance in respect of the recent media publications by The Independent and Sky News regarding the experiences of some people in mental health trusts who've experienced sexual assault or rape. This information was published following a FOI request in 2021. So I just wanted to outline the arrangements we have in place to support the safety of patients. And although the action plan specifically focuses on staff safety, it will impact on patient safety as well, because a workforce that feels safe and are safe invariably impacts on our culture and on the care that patients receive. However, we do have procedures in place for reporting, reviewing daily, collectively, any incidents regarding sexual safety that relate to patients. We have a weekly clinical risk meeting that oversees all incidents and any areas where we need to undertake further investigation. All incidents that are reported are overseen and sent through to our safeguarding team, who then review and make sure that the appropriate referrals to the police and the local authority undertaken, and we get a weekly update around the progress of those cases. We have robust procedures in place for managing allegations against staff and also for supporting any victim of a sexual safety incident. We have a 6-monthly report specifically on sexual safety that is produced by our sexual safety lead within mental health, that is reported through to the Safeguarding Learning Forum and through to QPAS. And we have work underway, which is quality improvement work, which includes co-production with patients to ensure that any areas we are developing is influenced and shaped by patient experience as well. It is proposed that a report is presented to Quality Committee in March by our lead in mental health and also the Head of Safeguarding to present our data and the procedures and support that we have in place. So I'll just pause there for questions. Thank you.
Thanks very much, Kate, and for explaining on that last bit. And just to be clear, for anybody who might be listening into the board today, that the independent report was an overview of a number of trusts around the country. It wasn't about us specifically, but it's an opportunity at board for you to obviously refresh everybody about what procedures we already have in place. And it's really good to see the action plan today. Obviously in September we agreed to sign up to the charter, and thank you for the work that's gone on since. Thank you. Priyanka.
Just a quick question. When I was reading that news article, I saw that they had mentioned that only a very few trusts has taken a safety, some sort of sexual safety audit, and just wanted to know whether we are one of the trusts that have done those audits. I can't exactly remember the name of the audit, so that I should have written it down, but I remember definitely that there were 2 audits mentioned, and they said very number of trusts have completed these audits.
Thanks, Priyanka. Kate?
Yes, so the Trust has undertaken audits previously and was involved in some national work a few years ago to develop our processes around sexual safety. There is a more recent document that's been produced, and one of the recommendations in our action plan is that we look at that document and reassess ourselves in light of that. But yes, the Trust has undertaken audits and was part of some national work around this area.
Thanks, Kate. Thanks, Priyanka. Stuart.
Hi, Kate. Stuart here. Thanks very much for explaining your report. Very clear. A question about the establishment of the sexual safety group. Have you got full representation? And yes, are there areas of the trust that you feel are not covered by representation?
No, we've reviewed the terms of reference, which will be going to QPAS in February for approval, and we've reviewed the membership, but we have got good representation from across the organisation, from our specific workforce groups as well, and from key partners in terms of safeguarding patient safety, all those areas. Yeah. Thank you.
Thank you.
Thanks, Kate. I can't see any other hands up. No. Thank you very much, Kate. Really appreciate that update and the additional information, topical information you provided today. Thanks for your patience in waiting for your spot. Cheers. Thank you.
No,
okay.
Thank you.
Thanks, Kate. Okay, I think we'll take a break now for 5 minutes. See you at around 11:10 and we'll reconvene. Oh, sorry, Hilary, did you want to say something?
Yeah, just to make
Apologies.
Sure that we confirm as a board that we've approved.
Oh yeah.
The
Do we approve this action plan? Gosh, thank goodness someone's reminding me. Thank you. Okay, well that is approved. We can all go to our break with that job done. See you at around just after 11:10. Thank you. Welcome back to Humber Public Board today, and we will begin our session again, and it's over to Pete for the finance report, item 11.
Thanks, Caroline. So this is the finance report as at the end of Q3. Within the report, I've put some information in on the wider system we're a partner in. So for Humber and North Yorkshire, just a bit of context, that as part of the financial planning reset at H2, as a system, we agreed that we would continue to deliver our original plan, which folk on the call remember was a 30 million deficit for the year. However, at month 9 as a system, we're reporting an adverse variance to plan of 18.5 million and are now forecasting to miss that deficit plan by just short of £6 million in the month 9 forecast. And that is primarily attributable to the recent industrial action. And that is across, mainly our other provider colleagues. So as a trust, we haven't reported any adverse impact, and that supports what Lynn updated on the call earlier. So I think it's fair to say there's a significant risk for the ICB to deliver its planned deficit for this year. And obviously, what's really of concern at a system and planning level is what that impact will be for next financial year. And as we sit here today, we are still waiting for the planning guidance to be issued. However, we do know that the business rules are going to be introduced into the planning guidance. So there will be an expectation that that deficit, whatever it is, will be repaid in future years. So quite a challenging financial outlook across the Humber and North Yorkshire system. But for the trust, it's a little bit more positive. So at month 9, we delivered a break-even position, and you'll see in the financial report, we are forecasting to break even for this financial year. The work we're doing at the moment is looking at our run rate, because it has got a bit higher in the most recent months, but we're just understanding what the impact of that is. We have been successful on recruitment, but some of that has led to a little bit of double running whilst we wait for student nurses to get the pins, etc. So we're hoping that will return to normal levels as we go towards the end of the year. You'll see in the report, our cash position remains strong at £27 million for an organisation aside. That is good, and we do have a really good performance on our better payment practice code, which is a good indicator of financial health. And whilst our agency is above plan, we have got a reduction on previous years, and Ian is leading the work through productivity group to look at that, and we also pick that up as part of the accountability reviews. And I've said this before in this forum, but we have a very strong oversight of agency spend at executive management team. I will stop there. That's a bit of a whistle stop tour. I'm happy to take any questions on the finance report.
Thanks very much, Pete. Mike and then Phil.
Thanks very much, Pete. Good, strong position. Every cloud has a silver lining. Overspending mental health, partly because of filling of vacancies and acuity and so on. That certainly allays my fears in terms of the previous underspend, which was due to vacancies and the effect on patient care. But what I wanted to ask you is, sometimes these things are a bit like a pendulum, that you go from an underspend suddenly to an overspend. Will we get to a settled position in mental health, or isn't that within your gift? You're simply monitoring it?
Well, Lynn's on the call, Mike, and I don't think we'll get to a settled position this year, just because some of the pressures we've had year to date, particularly agency spend, acuity, and out of area bed usage. But we have seen, and you'll see in the performance report, improved performance on out of area usage. I'm sure Kwame could update on where we are in terms of medical recruitment and agency spend. We saw earlier on the agenda, we've been successful with 2 recruitments, one of which is in the mental health division, and through the international recruitment, we have a trajectory to reduce our reliance on agency spend. And whilst we've had a wee bit of double running on agency nursing, whilst we've had the student nurses in post, I'm hopeful that we'll see significant benefit in the run rate on nursing agency spend as we go towards the last quarter of this year. And indeed, my expectation would be sustained improvement into the new financial year. So whilst it's early to say for definite, I have a level of confidence with the assurance I get when we have these conversations at exec.
That's fine, and I did anticipate double running being part of it, so I'm happy with that. I don't need any more detail. Thanks, Lynn.
Thanks, Mike.
Thank you. Phil, and then Stuart.
Yeah, it's increasingly important to understand the ICB position, but just to say that it reflects what's going on nationally, doesn't it? So, at the moment, there's very little coming out of the NHS to say what they're going to do about that. My question is about cash. I was just looking back at the end of last financial year, we had about 40 million of cash, and now we've got 27, which is still a strong position. But I just wonder if you could just explain what the reduction's about, Peter.
Yeah, of course, can, Philip. The most significant reduction in that, Philip, was the March payroll. So that didn't go out of the cash book to the 1st of April. So in the 40 million, there was still a month of payroll in that actual reported cash position at the end of the year. So that was the biggest drop in the cash. And then the rest is the normal day-to-day variation in debtors and creditors. And obviously, we do support the capital programme with a couple of million of cash every year, which is, you know, one of the reasons I'll often say when I'm out and about and folks say you've got all this cash, that's what we use it on, is the, you know, the capital infrastructure.
Okay, thank you. I just wanted assurance that we're not on a downward trajectory.
No, not. We're almost where we expect to be on cash.
Thank you.
Thanks for that question, Phil. Thanks for the answer. Pete, Stuart, and then Francis.
Thank you. It might be worth just for other non-execs just to say that the recent finance committee, which Francis chaired, we gave this report a really good interrogation down to divisional level, and we got quite a lot of assurance about kind of the position in year and what was being done about it. And the other thing I want to bring out is that you know, Pete referred in his introduction to the fact that we haven't yet received the planning guidance from National. So I'm kind of alarmed by that in one way, but it doesn't stop us getting on with our planning for next year, which I know is in hand, right, Pete? Just might be worth bringing that out. So it's not as though you're sitting and waiting with your sitting on your hands. There's work going on, right, to kind of do scenario planning and all the preparatory work to make sure we've got a plan ready for the year that's about to start. Well, in less than 2 months now.
Absolutely, Stuart. And we've got the first high-level cut discussion at exec on Monday, where we'll be rolling forward based on a set of assumptions. Obviously, when the planning guidance comes out, it'll refine some of that assumptions, and we're starting those conversations with our commissioners now in terms of level of funding and ensuring what we believe is recurrent, if that makes sense.
Yeah, thank you.
Francis?
I'll be very brief because Stuart's kind of made my point. We gave this a really good going over at Finance Committee, and I'll update later on the agenda about some of the key areas we picked up on. But to reassure or assure fellow board members, we really did it in quite a lot of detail. And as I said, I'll make some points later on.
Okay, thank you very much. And just to say that there's a meeting of trust provider chairs and chief execs on the 14th of February that the ICB have convened, which will be discussed finance. So particularly looking at, Francis, if there's any points you want to sort of send to me or any other colleagues, please do. And obviously, Michelle and I'll be liaising before that meeting as well. Thank you very much. Pete, thank you so much. Could we move on then to the performance report, please?
Lovely. Thanks, Caroline. So I'll be very brief, given I'm just conscious of time. So this is the month 9 performance report. You'll see within the report, you know, most of our performances are similar performance to what we've seen in previous reports to this board. You know, the positive I'd pick out is the workforce indicators and links to, we've got the people strategy earlier on the agenda today, and some of the positive updates in the chief exec report. And I think that kind of complements that. You know, also positive to the clinical supervision above 90%, which I know is often a focus of this board. And I think, you know, just one for me, noting the continued improvement on talking therapies. You know, I have to be careful. I often call it IAP, still I go a bit old school, but, you know, just seeing that sustained is really positive to see. We know waiting times is an area of focus, and we are reviewing that as part of the discussions we have at exec. I guess what's critical to that for me, and it links to the previous conversation, is whatever happens as part of the planning guidance and any funding settlement that comes out will indicate where we think we can or can't get to in terms of waiting times next year. And I'll stop there. I'm happy to take any questions or if any of my exec colleagues want to add anything.
I'm looking around. No questions on that. Okay. Oh, sorry, Stuart.
Yeah, sorry. Yeah. So I'm on page 155 of the pack, and it's the chart on the number of children and young people accessing support by NHS funded services, etc. And it's kind of that steady increase in essentially our workload, you know, up from, I think, 5,500 18 months ago to nearly 6,800, which is kind of, we've talked about this before, haven't we? Just this this rise in the burden of what we have to cover. So leaving aside what we don't know at what will happen at system level, which will affect us, how are we at the moment reflecting that increase in workload in our internal planning intentions at the moment in respect of resource allocation or staffing levels and so forth? And I don't know whether it's one for Lynn or for Pete, but I just want to note the fact that we've got this very clear evidence of an increasing workload.
Pete?
Yeah, I'm sure Lynn will jump in as well, and we'll do a bit of a double act on this. So, this activity is primarily delivered by the mental health support teams, for which there has been service development funding and phases of rollouts over the last 4 or 5 years now. I'm trying to remember how it was pre-pandemic these teams started, and we continue. So we have got expansion in those teams this year that are coming online in October for, and I might get this the wrong way around, and then they'll correct me, for the East, I believe it's for the East Riding, we're on phase 7 as a rollout. So that activity, it's almost one of the exceptions for us, Stuart. It's one of the ones that actually is resource backed, believe it or not.
Okay. Thank you.
Okay, Lynn is nodding there. I think nothing to add there, Lynn.
Pete's correct, Jess.
Thank you.
Okay. This was expected and planned because it is about those new teams in terms of this particular chart. But you're right overall, Stuart, we are still seeing that overall rise in children's activity. Yeah. It's starting to plateau, but what we're still seeing, as I keep reporting here, is that real complexity in those children and young people's presentations as well. So obviously we have been doing a huge amount of work, obviously focused around capacity and demand planning. In relation to that, we've just virtually completed now. We've worked with an offer we had from NHS England. It's called a CLEAR project. It's a project really focused on working with teams to really understand clinical practice processes, aligned with activity, aligned with finance, and aligned with workforce. So that report has made some recommendations. They'll come through the trust governance process now as well. So we're pleased to see that. That's added to the already sort of quite an in-depth understanding that we've had of these services, but that's just helped a little bit further as well. So I think we're doing everything we can to really understand that children and young people's position.
Okay, thank you. Phil?
Yeah, obviously a couple of big areas of problems for our trust, like a lot of other trusts, is staff, workforce, and waiting times. With workforce, I'm really pleased to see vacancies reducing and turnover reducing. With waiting times, it's brilliant to see East Riding talking therapies improving and adult ASD long waits much improved. Obviously ADHD is a bit of a problem still for long waits. But today I just want to ask about from June onwards, the waiting time for memory diagnosis has started to increase again. And I just wondered, is there a particular issue within that? Because the volume of work's not going to go away with an ageing population, and obviously these people have got a limited lifespan. So people waiting a long time to understand what's happening to their loved ones is quite an issue.
Lynn?
I can pick that up, Chair. So, Philip, we have undertaken very detailed capacity and demand analysis. We've really focused on clinical and operational processes. We've taken a very detailed paper fairly recently to the executive management team around the outputs of all of that. And obviously it does show that our resource is being used effectively. It's a growing issue around increasing demand that's causing the waiting list issue. We are having conversations. Obviously, we're in the midst of the conversations with ICB colleagues around commissioning intentions for next year at the moment. So we absolutely are able to articulate incredibly well where we are with that. But it is a resource issue, Philip. We can demonstrate that due to rising demand. We are doing everything that we can to work innovatively around memory services. It's also an area of focus in the Mental Health LD Autism Collaborative as well. They're doing so, because we're not the only area that is challenged by memory service waiting times either. So that ICB piece is really helpful too. So I can assure you we are doing everything we can to try and address the position.
Lovely. That's really helpful. There perhaps is a bit of work maybe with primary care as well, because obviously people that are in care homes are very obviously got significant dementia. In the past, you were allowed to diagnose in such like in primary care.
Yeah.
That needs to change. I think it is changing, but maybe I don't know whether that's some education or sort of teamwork with primary care as a whole would actually take some of the demand off.
Yeah, absolutely. We do that anyway locally, Philip, but I think it's fair to say there is some variation across primary care in response to diagnosis pathways for memory assessments. The ICB piece has also picked that up, and we are connecting with the primary care collaborative around that piece to join what we're doing with that collaborative work as well, in order that we've got clarity around what's best practice and that's being applied consistently across services.
Lovely. Thank you, Lynn. That's very reassuring.
Thanks. That's great. Thank you. I presume, Lynn, also as well, for as you get older and everything else, it's also all those voluntary sector organisations who are involved in lots of different, both physical and mental activities with people, to sort of, it's not going to be the same in every circumstance, but to keep, basically keep exercising your brain as much as you possibly can in different situations is really important as well to all of this.
You might be aware, Caroline, we've actually worked quite closely with the voluntary sector exactly around that area of work at the moment. It's going to be interesting as we sort of understand what the intentions are for next year around some of that provision as well, because there is some risks in that currently as well. See David's nodding his head. So we do have some sort of brain specialist workers provided through the voluntary sector. They've been brilliant, I have to say. They really do add in a really important dimension, but they are commissioned through local authorities. So lots of discussion taking place around that right now.
Thank you. David, I've sparked you coming in there.
There's a very pessimistic outlook in the charity sector right now for next year and the year after. I think that the loss of some of our voluntary support services should absolutely be on our radar and potentially our risk register, because it will have a knock-on effect on not just our services, but the whole range of statutory services.
Okay, thanks for that. Okay, right. Therefore, we note the performance report. Thank you very much, Pete and Lynn, for that additional contributions there as well. Okay, we move on then to the risk register. Hilary.
Thank you. I think Oliver, Oliver's on the call. Yes, risk register here. As you can see from the narrative on the front sheet, when we looked at this at EMT last, we're scoping up some more risk areas as well to consider whether or not they need adding on to this as we move forward into 24-25. But I'll hand over to Oliver if there's anything in particular Oliver wants to say, but then otherwise take some questions if there's any from the board.
Okay, thank you. Oliver, sorry for keeping you, Oliver.
That's all right. Thank you, Caroline. Thank you, Hilary. Yeah, so as Hilary mentioned, obviously this represents the, I suppose, the risk register position of our highest rated risks for an end of Q3. Obviously, it was considered early January by EMT, and there was that discussion around what risks we should be thinking about, obviously going into Q4. So particular areas of focus came up, which have obviously been touched upon today, obviously looking at trust finances, out of area patient placements was another consideration, rollout of the electronic patient record, and obviously the trust estate. Quite a bit of work has been undertaken thus far. Obviously, we'll continue to look at those risks on the lead up to next reporting to the board subcommittees and to trust board. Out of area placement risk is currently live on the system, doesn't currently meet the threshold for inclusion on a trust-wide risk register. I think we have seen a slightly improved position there, but obviously we continue to monitor that, and it's regularly discussed by the operations delivery group, and obviously if anything does change there, then we would be escalating accordingly to EMT and then potentially for consideration and inclusion on this document. In terms of sort of wider work, obviously we're also going to be considering the risks that are currently held on the Humber and North Yorkshire Integrated Care Board risk register, and any risks that we need to be considering linking in with the wider system, which I know has obviously been touched upon briefly as well in terms of that wider sort of ramifications. And that's something that we'll build into process as well. I think we're all coming to sort of terms with how that's going to work and how the trust can interlink with their risk register, their board assurance framework arrangements. And it's just kind of learning what that needs to look like going forward. So there's some work specifically planned around that, which will take place over the next coming months. But ultimately, obviously, 4 entries that carry over from sort of into the Q3 position. Obviously, operational workforce focus. I won't go into the specific entries. You'll be familiar with them somewhat for what's carried over from Q2. Happy to take any questions, any queries, or any sort of feedback around process and how it's all looking to date.
Thanks very much, Oliver. Any questions to Oliver or comments, please? Francis.
Just a minor one, very thorough as ever, Oliver, so well done. Just on the what additional actions need to be completed, we're obviously getting to that time of year when I presume you're going to review those actions to see whether they've been completed or not and what impacts they've had on the risk and whether they have actually lowered it, because they've been on there most of the year. So it's a question of just reviewing. We said we were going to do them. Have we done them? And have they made any impact whatsoever?
Oliver?
Thanks, Francis. Yeah, we'll be doing the annual report coming up sort of in the Q4, maybe just into Q1, but obviously that'll be a big part of that review. So obviously, as ever, we'll do a full consideration of that. And then I think that'll also come to audit committee as well, just for further assurance aside from EMT. So that is in train, and thank you for flagging that. I think that's a really key point. It's something that we factor into the process each year as well. Just to, obviously, we don't want to have risks that are static and are not moving, but obviously some of these are quite big issues, big ticket items for the trust. So again, it's about giving that consideration to the actual impact and those mitigations that we've identified. So yeah, that will be considered. Thank you.
Okay, thank you. Stuart?
Yeah, more a comment than a question. It's just going back to our earlier discussion about the people strategy. So three of the top 4 risks specifically mention workforce capacity in a nutshell. And it kind of just re-emphasizes for me that the issue about capacity and our ability to respond to things remains very, very kind of intransigent. It's been around ever since I've started on this board and continues. So that, I mean, I endorse the work being done to kind of get this filtering going on, to bring to our attention as a board the key issue. But I just want to make that point that it's so often comes back to workforce and capacity. Leaving aside the pressures on the resource that might come around, it's our kind of bête noire.
Yeah. I think that's noted by everyone, Stuart, and yeah, thanks for mentioning it publicly today again. Okay, any other questions to Oliver on this? Oh, sorry, Hilary.
Sorry, I've got a question on the report that I've done. I've just noticed on LDC 82, the last risk, we haven't got the dates for those actions on there when we expect those to be done. Right. Can we just review that, please, with the lead?
Yeah, absolutely. We do have dates. They just, I think, might be missed off in transition into Excel. Yeah, absolutely. I can recirculate just some confirmation around that as well, just to provide that assurance. But the dates are on the system, so it's just how it's pulled through. Apologies.
Thank you.
I like it when executive directors raise questions and point things out. There's nothing wrong with that, Hilary, at all. Great. Okay, thank you. All right, then we'll move on to the board assurance framework then. Oliver, please.
Yep. Thanks again, Caroline. So again, representing the Q3 position, I think originally on the work plan, this was going to be coming in November, which was obviously fairly early into the quarter. Obviously, just to allow us to bring some more of the, I suppose, the data and the up-to-date position from the full quarter. We've pushed it on now, obviously, to January board, and we'll be doing something similar, I think, for the Q4 report. So just to allow us to obviously collate as much information as possible, just to show any movement, any specific areas of assurance that we need to reference for the quarter. As ever, obviously, it's in the new style that we've commenced with for this year, which I think is working really well. I think moving us away from very much risk focus to looking at that overall picture for each of the strategic goals. Again, in line with the risk work that we'll be doing, looking at the wider system risks and what's currently held by the ICB. We'll be doing a similar sort of activity around the BAF as well, and anything that we need to consider for inclusion. Obviously, their format is slightly different to ours, so it's not a case of just lifting and shifting. It'll be very much looking at that position from that system-wide perspective and anything that we need to be considering, anything that potentially could impact on our specific delivery of our strategic goals. But again, I think that, in terms of how it's developed, I think it continues to be a very iterative process in terms of bringing the BAF on. Obviously, it's moved on quite considerably from what we were doing last year, and I think it's been really well received by the board subcommittees and obviously feedback from board. So obviously we'll continue to go with this format, but obviously come the end of year, when we do the Q4 report, we'll think about anything additional we can include for Q1 of next year and further sort of so any developments and things that we can improve ultimately. So as ever, really happy to receive any comments, any questions, anything that we need to consider specifically going into Q4. And obviously the next step will be bringing it to the board subcommittees in terms of its developing for that Q4 version of the report.
Okay, thank you. Hilary.
Just a couple of things to bring to the board's attention. Under the quality and patient safety in terms of positive assurance, that significant assurance we've been given by internal audit for our approach to how we do our trust safer staffing audits, which is the next paper that we've got. So just wanted to make that connection for the board. We've also just got significant assurance for the way that we close off our actions from patient safety incidents as well. We only got it last week, so obviously these papers had already been done, so that will go into this section of this report going forward as well. But that was really positive to get significant assurance for that work as well.
Oh, thanks, Hilary. Thanks for that timely update. Actually, that's really helpful. Thank you very much indeed. Okay, I'm just checking if there's anything in the chat box there. No, that's just someone having a problem on the internet. Okay, all right then. Thanks very much, Oliver.
Thank you very much, everybody.
Do you think, Oliver, there'll be a time when, you know, across the ICS we might have not the same content but the same format for these things? Is that a goal they want to do? To harmonise some of these?
I don't think there's been anything, or at least that's found its way to myself or to the exec team as far as I'm aware. I think ultimately we need to have similarity between sort of the organisational documents, and we did take a bit of a lead from what they were using previously, but I think they've further changed what they're doing. So I think us undertaking that review will be a good first step. I think I know our internal auditors are looking more around how we're linking in with the system and how kind of bring that sort of harmony between, as you mentioned, between the different sort of BAFs that are used. So potentially, but I think it's still a bit of a work in progress at the moment.
Fair enough. Hilary?
A little bit on that point. I think it's next week at EMT. We're looking at the ICB risk register, aren't we, as well, to see if there's anything on there we need to take consideration of for our own risk register as well.
Yeah, that's good. Thanks, Hilary. Thanks for that information. That's really helpful. Okay, right. We will move on then to the 6-month review of safer staffing. Hilary, over to you. And we're looking to ratify this today.
Thank you. I think we've got Sadie on to actually speak to the
Sadie's
document.
here as well, sorry.
Yeah, just to give it a bit of an introduction, because the board will, those that have been on the board for a while will see that the format of it has changed. We've moved away from all that narrative and trying to make it more the indicator, so hopefully it's an easier read. But we've also done that to link to item 18 on the agenda today, that rapid review into data on mental health inpatient settings, where we said we would put more quality indicators in and pull them together in this way so that you can look at it over previous 6 months as well to see what the position is really, whether or not it's an improving position or not. So Sadie did all the work on this, so I'm going to hand over to Sadie.
Thank you, Hilary, and thank you, Caroline. Yes, so I'm hoping this new report will be well received. It's certainly, there's been a lot of work going to this, but I think it really does sort of demonstrate, doesn't it, that over time, the progression that we are making in terms of safer staffing, looking at all the quality and performance metrics alongside that. So following this round of recent reviews, where all units did actually complete their data collection this time, which was really positive, we were able to give really good assurance around our units being safely staffed, with 18 units demonstrating good assurance. In respect to the care hours per patient day, we continue to perform well when compared to our peer and national medians. We have completed the NHS England MHOS training now, so we have got a sufficient amount of staff trained across all the divisions where that tool is relevant, and we are continuing to cascade that training throughout this quarter. So that is a much stronger position that we were in before in terms of that inter-rater reliability. So following this review, there are a number of recommendations that are outlined in the report. However, we're not making any recommendations to the board around changes in care hour per patient day or budgeted establishment at this stage. And just to follow on from what Hilary was saying about the internal audits, which we got the significant assurance from, we had 7 minor recommendations, all of which have been completed and actioned within the timeframes. I'm happy to take any questions. Thank you.
Thanks, Sadie. Thanks for the work you do and all your team. And it's great to have that from internal audit, providing more assurance as well. Thank you very much. Any comments or questions for Sadie or Stuart?
Hi, Sadie. Question about Millview Lodge. So Millview Lodge has got a few red zones in your report, and they seem to have been red for some time now. By contrast, Millview Court is moving from red to green quite comfortably. Is there something specific about what happens or what the conditions are at Millview Lodge, which means it looks harder for them to have the staffing levels you're looking for?
Well, it's really timely actually, because I've been cited on the most current dashboard today. And that actually demonstrates that Millview Lodge have significantly improved across the board. So there's no red flags this month for Millview Lodge. So they are clearly making really good progress in terms of their supervision and some of the other metrics, and the fill rates have improved as well. Sometimes it's a system that's the issue, where we just have to make sure that the demand templates fit with the system. So those corrections have been made by the roster team, so that's significantly improved their position for December. So hopefully that'll pull through on the productivity report for the next 6-month period.
Oh, great, that's good, because it also reflected in the performance report we just looked at. Millview Lodge stood out a little bit in the dashboard, so that's good to know. Thank you. Yeah,
Great, good to have that fresh information. Thanks, Sadie. Francis.
Hi, Sadie. Thanks. I really like what you've done in the report. It's great. I'm a visual person, so I think it's a really good way of presenting it. I like all of the, the previous quarters, etc. My only comment would be, if you look at it visually, there's a lot of red and orange, but then when you look at the comments, it says good assurance. So I'm convinced there is good assurance. It's just that it does look a bit weird when you see lots of reds of orange and then see good assurance. So it's kind of an overarching comment, really, not a criticism, but it just struck me as I was flicking through it how much red and orange I could see, but we were getting good assurance below.
Yeah, I think over time we can see largely that the reds and oranges are starting to turn green, which seems positive. In terms of the RAG rating, we take that from the trust thresholds. In terms of where the cut-off points are, in terms of the training, the clinical supervision, friends and family tests and sickness, etc. So if there's another way you'd like this presenting, then I'm happy to take your comments. Thank you.
It's not another way to present it. It's just visually it gave me a slight disconnect. I was flicking through it thinking, oh, there's lots of oranges and reds. And then I was reading the stuff underneath where it says good assurance. So it was just the way it comes across. I think it's great. I really like the way you've done it. It's just when I was going through it, that's how it came across. I'm sure Hillary's going to come in with a comment.
Hillary.
Yeah, thank you. I think it's that point, section 5, where we've pulled out low assurance where 5 or more indicators are under the low target threshold. So we've put those thresholds in, which have been there now for many years, to give that indication. I mean, we can revisit those and have a look at them if we think that maybe so many reds should equal something different, but they seem to have worked for us for now, because particularly, obviously, you've got to remember, as the board, you get the monthly safer staffing as well, so there shouldn't be anything new in here. This is what you've been seeing over the months. This is just where we bring it all together, isn't it? And we've already seen, isn't it interesting that Millview Lodge flagged here on this report, but also on this month's, well, it's not this month's data, but in the board this month, Millview Lodge flagged for 5. Lynn and I were there last week, weren't we, Lynn, to speak to the staff, see how they were feeling, talked about clinical supervision, etc. So we got some reassurances on that, and that's good to hear from Sadie that that's moved forward. So it does seem to work, and certainly having used this methodology now for about 7 years in the trust, it certainly does help to flag those units where we've got some concerns once they hit that 5.
Okay. Happy with that, Francis. Thanks for raising that point. Good. Okay. I can't see anybody else with hands up. I think that's a legacy hand, isn't it?
It is, sorry.
Yours. No, don't worry, it's fine. It's fine. So can we please ratify this report, please? Yeah, everyone happy with that? Great. Sadie, thank you so much.
Thank you. Thank you for your time.
Yeah, and yours. Thank you. Moving on then, Catherine, thank you. Sorry for keeping you waiting, Catherine. 6 monthly research and development report. Kwame, did you want to say anything, or should we go straight to Catherine? You're on mute, Kwame.
Sorry, no, Catherine, please go for it. I think there's a lot of positive in there, and Catherine can articulate them. Hello, Catherine, welcome.
Thank you. Catherine.
Thanks, Kwame and Caroline. Okay, I'll just quickly fly through some of the highlights in the report. So just in section 1, just thinking about performance, just to let you know that we've got 44 national studies running across the trust at the moment, National Institute for Health Research studies, and we've got 12 that are classed as non-NIHR studies. So if you have chance to look at Appendix 1 in this report, it shows the huge breadth of research studies that we've got going on in the trust, from kind of sexual safety to malnutrition to diabetes to dementia, artificial intelligence. We've got all sorts of things. So Appendix 1 is worth a little look. And just in terms of performance, we have a recruitment target that is set for us regionally, which is 660, and we've already far exceeded that. I think we're at about double that at the moment. So we've hit that target. In terms of awards over the past year, we were shortlisted for various awards. So I thought I'd just pop that in. Ruby Watson, who's a volunteer as well, who volunteers in research. She's the research champion for us. She was shortlisted as well, which was lovely to see this year. Just going on to governance, I think I've mentioned this before, but we've now had formal notification that the Yorkshire and Humber Clinical Research Network will now be hosted by Leeds Teaching Hospitals from October this year. So it has been hosted by Sheffield Teaching for many years, and that's who our contract is with for the majority of the research delivery funding that we receive. So that will transfer to Leeds come October. We'll hear more about that over the coming months. Section 3, just to let you know that the refreshed research strategy has been written now. It has been through QPAS and EMT. It's about to go to Quality Committee, so you will be seeing that shortly. So that was overdue, a refresh, but you'll see that shortly. And in the previous board that I came to, there was a request to do a report on nursing involvement in research, and that has been done. We've done quite a thorough report. That's been to QPAS as well. And I mean, it really shows that we've made a lot of progress in the past few years in terms of nurse contribution to research, including in terms of developing new research ideas for national research grant funding, being on things like the Associate Principal Investigator Scheme, which is a new national scheme. So there's all sorts of ways that nurses have got involved, and we've done something similar around AHPs as well. Section 4, which is around funding. I suppose it's just to raise the thing that I mentioned about the research delivery network moving to Leeds Teaching Hospitals in October. Potentially that could present a risk in that they may decide to start funding using a different funding formula. We've benefited through our performance in the past few years in terms of the way the funding formula has worked. Hopefully that won't change significantly, but it's an unknown at the moment. So I suppose that's just a slight risk in terms of future funding. But given that we're doing more and more research, you know, we should be pulling in more and more research funding. Because of our recruitment, we also get a little bonus at the moment where we get an extra 25k from Department of Health. And we can use that to, it's called research capability funding. So it's meant to help build our research capacity. And we've been using that to fund a clinician this past year in perinatal mental health, who has contributed to some research grant applications, some of which we're awaiting to hear the outcome of. So hopefully they might be successful. Section 5, opportunities, innovations and alliances. I suppose it's just to point out, looking at Appendix 1, over 50% of the research we do involves novel interventions. So that's brand new treatments and therapies. for our patient population. So I think it's worth noting that. And something we've been trying to achieve for quite a while is to get commercial research underway in the trust. And we've got our first commercial study that has just opened in primary care, so in our GP practice, called the Taste Mood Diagnostic Study. It's around depression and taste. And I'm not an expert on this, but apparently there is a link between the brain and the tongue and taste and depression, and we're looking at a test around that to see if it helps inform antidepressant prescribing in the future. So that's quite an exciting study that we're involved in, and we're hoping to develop more of the collaboration with commercial research moving forward. Section 6, looking at kind of learning, engagement and impact. We're planning for our next research conference, 22nd of May. Hopefully you've all got it in your diaries. The in-person places have sold out. I know we don't charge, but they've sold out. But we do still have online places. I think we're probably at about 300 that have registered so far. And we've got a great lineup of speakers. And just moving down that section, I've mentioned this, that we were going to be involved in a pilot around incorporating student nurse placements with research so that research becomes an intrinsic part of the student nurse placement rather than just having a day with the research team. Actually, the clinical placement involves being with the research team a few days for weeks at a time. And we've had feedback on that and it's been tremendous. We were the first site nationally to do this. We're part of the pilot programme and we started it first. So all the other sites are kind of looking at how we're implementing that, and we're all doing it slightly differently. Ours is quite structured and they get a chance to go out and shadow us when we're going out and seeing research participants and things. So there's some feedback there in the blue boxes, but it's really been positive, and we're going to present on some of that in the conference this year as well. So that's all about creating that, we want to embed research as part of our research strategy. It should be part of frontline services, and that's one way we can make sure that happens if we get students right at day one. And actually something that's come out of that is the students themselves recommended to the university that all student nurses should complete what's known as good clinical practice for research. It's a certification that you need if you're going to be involved in research. And the university is now going to ask all students to complete that as part of their student nurse training. Just moving down, I thought it was worth just mentioning Claire Marshall, who is somebody that we're helping develop research grant applications with. And she presented at a conference in Switzerland some of her research. Recently, she got a bursary to go and present that, which funded her to go. And it was nice to see that the CEO of the Maternal Mental Health Alliance, when she visited the trust, actually commented on the perinatal mental health service and the fact that they were doing research and how this was improving services. So that was nice to see. Section 7, EDI. Some of the research team are involved in the new Health Inequalities operational group, and we're trying to do a lot more to reach out to populations that we haven't traditionally been engaging in research. We're investing quite a bit of time in that. And we've also committed to every single member of the research team completing the Introduction to Cultural Sensitivity training, which is the national e-learning module for researchers. And we're going to include that as part of induction for all new staff in the team as well. So those were some of the highlights.
Great. Thanks very much, Catherine. Shout out obviously to Claire Marshall. Karen Foster, I think, got celebrated in the CRN annual awards, and Heidi Fewings, I think, as well. And you mentioned Ruby Watson, too. Great for those individuals, and really interesting hearing about Claire's recent presentation in Switzerland as well. On the Leeds, the transference to Leeds, obviously, thanks for flagging that. Do you know when you will know what they are going to do in terms of the funding formula? Have you got a sense of when that's going to happen? Because if they're taking it over in October, when will you sort of know?
Yeah, we've been informed that there will be stability initially, so we don't expect major changes. Michelle might want to.
Yeah, Michelle's on the research body, aren't you, Michelle? Leading on that, aren't you, Michelle?
Yeah. I think we've noticed here before what the contract has changed. We were looking at changing the contract from the Yorkshire and Humber Research Network anyway, but it was part of a national national piece of work to relook at and rebadge clinical research networks across England, partly to try and get some more coterminous with.
Oh, Michelle, you've gone on mute.
Sorry, I don't know, did that. I said I've been having problems with Teams. So as you know, I currently chair Yorkshire and Humber Research Network. So we're just in the transitional piece at the moment where we're going from one contract to another contract, but it's more detailed than that. There are actually some structural changes with posts and operational aspects of the CRN. So that's what we're working through at the moment. In relationship to the funding model, we've spent a lot of time over the last few years, particularly in Yorkshire and Humber, in changing the funding model, because the funding model was predominantly geared towards acute trust. And when I took over the chair about 4 or 5 years ago now, probably, I wanted to change that funding model to make it more equitable across the landscape. So we started to look at changing some of that and put money into primary care, into community mental health services, which is why you've seen some of the slow shift. So because we've done that as a Yorkshire and Humber, the national team have adopted that model. So in answer to the question, we're not anticipating too much in relationship to change from the model point of view. The detail is what is the bottom line in relationship to the money, and we don't know that yet given the Treasury situation with NHS funding in general. But from a model point of view, we expect it to be very similar. The transformational piece should be finished by October this year, and the bulk of the transformation we've got the infrastructure sorted now, the bulk of the work will take place over the summer months. We've got the appointments in place, and it will take that time to do it. So that's a little bit about the network. Just in relationship to the report, I guess I've got my hand up, so I'll just jump in front if that's sure. Okay. I do want to compliment on the commercial study, because one of the things that we need to do more of is commercial studies. So it's quite good from an organisational point of view that we're flying the flag on that. And it sounds a really exciting project, and I want to wait and see some of the outcomes of that. So I think that's really important. And also the student aspect as well. I spoke to some of the students as well, and they really did enjoy it as well. For me, the key thing, and we'll try and embed this in the new iteration of the network, is how we embed more the research work into ICB strategy, and how we follow that through in relationship to how we make a change from the research and put that into practice across systems. So that's one of the things that we're looking at the moment. But thanks to Catherine, she does a great job. It's and the research conference is always fantastic, and some great speakers, and I'm looking forward to it already, even though it's May and I don't want to get to May yet, because I like to get through spring. I want to get to spring first. So, but thank you. Hope that was helpful.
Thank you, Michelle, very much. Dean?
Yeah, thanks, Caroline, and thanks, Catherine. Not so much a question, more just a sort of observation, really, about strategic delivery on this. So it's great to see this report coming, and each 6 months, Catherine, you can see it sort of building and becoming more and more embedded and growing and becoming more an integral part within the organisation. It's just I was mindful of David earlier talking about delivery on strategy, and it was a few years ago that we changed our name to had teaching into the title. And I think there's a real strong link here, isn't there, with the research and the teaching and the culture change that then follows from that over that period of time, in terms of, you know, things like retention and our ability to recruit those coming through. So that delivery on if you like, you know, culture, we always talk that culture change doesn't happen overnight, it takes time, but sometimes in this report you can sort of see that journey sort of coming through, and it's great to see. And again, really helpful today, because on the social value work, you know, more and more patients in our catchment area getting involved in trials that are going to impact upon their health positively, that we hope. And so it all sort of comes together in there. So it's really good to just see that sort of embedded within that, you know, the change in title to a teaching trust wasn't just a change in title, but that teaching and research being so clearly linked. So great to see.
Yeah, thank you for Dean. Thank you for that, Dean. It's really important. And I think last time we heard from you, Catherine, I think I'm right. I think it's 100% of our GP practice are involved in research as well, which is a highlight of last time I think we had the report. Thank you so much. Really great. I would have to say, I mean, not having taste would make it a very grey world. It's about a bit like not being able to smell. Wasn't it during COVID that some people lost their sense of smell during COVID? And it's actually, you know, well, I mean, that's going to be really interesting to see any connections there. But goodness me, if you couldn't taste stuff, how dull would it be, really? But yeah, okay. Thanks very much, Catherine.
Thank you.
See you in, well, bye. If not before, see you at the research conference.
Thank you.
May. Take care. Thank you. Bye. Okay. Oh, right. Now we move on to item 18, and it's Stella. The rapid review into data on mental health inpatient settings action plan.
Okay, so I'll just be brief on this one, but the board received a report about this review in August 2023, and the context within it in the paper outlines its purpose and how it came about. The review resulted in a number of recommendations, which they generally do, don't they, that the reviews that are undertaken. And it was agreed at the board meeting that an action plan would be produced at the trust in response to those recommendations. So the action plan is attached to the report. As you will see, the majority of those actions have been implemented. There's just one or two outstanding ones which are in hand, and it's here for assurance.
Thank you. Any questions to Stella on this? Mike, please.
Thank you, Stella. On the cover sheet, it says, despite the data burden, patients and families and clinical teams are of the view that the system is not measuring what matters. So I just wondered if you could tell us a bit more about that, and whether, if it's not in terms of this reporting, whether the trust as a whole measures what matters.
That might be something, Mike, that I just need to defer to a colleague, either Hilary or Kwame.
I presume that comment is what's been fed back to the national sort of review on this. Yeah, yes. Okay. Yeah. I did do a little asterisk against that just to clarify. That's where they've looked, and that's why they've asked us all to look at our own action plans and make the relevance there as well. Any EMT colleagues like to come in on that? Kwame?
No, I think you're right. That was the national reflection, that data was being collected, but it wasn't triangulated and it was becoming a burden. So part of the conversation we just had around safer staffing was almost to make data meaningful to the staff on the ground, who should collect it once. And then once it's collected once, it's become meaningful. And that is one of our agendas, which we are carrying forward. We're hoping that with our new electronic system, which again, that would help us to collect data once at the front end, and then the data then is used across the trust. In the spirit of what Geraldine Grading was saying about data, not necessarily about trust, but in general in the country.
Okay. Phil?
Yeah, I struggled a little bit with this review because obviously it's about data on mental health in patients, and then the recommendations seem very heavy, particularly relating to the board. And I just wondered, have we reflected what we're going to do fully about the recommendations relating to the board? Because some of our action plans probably seem proportionate to the issue, but don't seem to fully answer the question. So, like, every provider board should have an expert by experience in carer representative, and we've put that we just have a regular program of patient and carer stories at the start of the board meeting. I'm not sure that meets the recommendation, but I'm struggling a bit whether the recommendations are a bit heavy, and obviously there's yet more training for boards to do, and there's things like out of our board level visits which we're taking on, we're doing those, and then some mandatory training on data literacy. But it's just that I felt there was like disconnect between our answers, but probably our answers were appropriate to the issue, but not the level of recommendations. So there was just a bit of disconnect there. I just wanted to explore a little bit.
Yeah, I hear what you're saying there. Michelle, do you want to come in on that?
Yeah, I mean, it might be we take it back to a strategic board conversation, Phil, because we did pick this up at one of the strategic board sessions and obviously develop the action plan from there. And I take your point. This was about Edenfield predominantly in the main, and there are some heavier pieces that I think for me, if we look at it, maybe it's the way it's wording. I think we are tackling the majority of or all the recommendations. I mean, data literacy, we're still waiting for a programme. We've had lots of different quotes, so we're going to probably do that in-house. So there's things that are still ongoing, which are in the report. But I think if it's a way of wording, it's narrative, I think, maybe we just need to discuss it in a bit more detail. But I think it is here for that comment. But it could be quite a lengthy discussion. So I'm just suggesting if we do feel it needs a longer discussion, then we can take it into the strategic board session again and maybe have a look and see, well, a few months on, where are we up to with these? Is it still applicable? Because there's obviously been other recommendations and other guidance that's come out since. There'll obviously be some other things from like Let Be, etc. So I don't know, maybe that's the better forum to maybe have another refresh look at it. Just a thought.
Yeah, I'd like that, because I just felt that I don't think we should just slavishly implement these recommendations, but I think it is really important that we have a proper considered discussion about which ones are important and which ones are probably not appropriate, or how that we fulfill the spirit of the recommendation without damaging the board.
Yeah, I think that's a really valid point. Shall we why don't we take that away and think about coming back to this at a strategic session at some point to have another little refresh look at it? I think that's a sensible suggestion from Michelle, and thanks for raising that, Phil. Great, okay. Any other questions on this? Okay, so with that prompt for further look at this at a strategic board, thank you very much, Stella. We'll move on then to Hull Community Plan 24-2034. Michelle?
Yeah, thanks. I'm not gonna labour on this. It is here just for information, because obviously this is just one of the places that we represent. We go into the majority of the places, we do see their plans as they come through, and obviously we'll get a lot more information from the devolution plans as they materialise. I thought it was quite useful just for the board to be aware of it. We have contributed to this. The council have signed it off at their last meeting. So it goes through the ambitions and the commitments, just to reassure the board that, as I say, we are collectively part of this in various different ways from an executive and other members of staff across the organisation, and obviously we'll monitor it through the usual strategic routes. There is a tentative link into the ICB. I won't say it's a bold link into the ICB, but there is a tentative link into the ICB strategy as well. But I'll leave it there, Chair, given time. I'm hoping it's just for information and people find it useful. But I just thought it was quite a useful document, because it is such a lengthy document as well, vis-a-vis it's 10 years. So I'll leave it there. Thank you.
Okay, thanks for that. We'll note that, and obviously we can have time to look at that in more depth. Moving on to the Assurance Committee reports. Francis.
Thanks, Chair. As I mentioned this earlier, just to say we had an excellent meeting. The quality of the papers has been really, really high recently, which gives us really good quality discussions. We got great assurance on the financial position and the year-end outturn, and on the planning that's in place for next year. And listening back to what we discussed earlier, and we also got very good assurance on the Be Digital and what's going on within the Be Digital projects. And our only concerns really were on the financial state of the NHS and the ICB, which is why we were pleased to see the planning that was in place for next year, because it's obviously going to be a very tight year next year, and even most of the messages coming out seem to be fairly negative. And we also had some slight concerns on primary care and agency, which have got ongoing monitoring plans through the executive team, which come back to us. That's all. Thanks, Chair.
Thanks very much, Francis. Any comments? No, thank you very much. Move on to charitable funds.
I think Pete's got his hand up.
Oh, sorry, missed that, Pete. Sorry, apologies.
Sorry, Caroline. Just very quickly, we did review 3 documents in the committee, which we know were a focus of the ICB in relation to planning and overarching financial position, and that was just a detailed review of our workforce growth and the impact on productivity, an assurance that we have got control in any expenditure over £10,000, and we were assured that the controls we already have in place are adequate and nothing's creeping through that we might have put the brakes on. And just finally, just that the actions we put in place as already had in place, dare I say it, in relation to the planned feedback letter from NHS England, we just took assurance that actually we've got good systems and process of governance across all areas in the organisation. So I just think it's worth noting that.
Yeah, thanks, Pete. Cheers. Okay, Stuart, charitable funds annual accounts for which we are being asked to approve as the corporate trustees. Stuart.
Exactly right. So this is the report ended March 2023, so quite old in sense of we know that things have moved on since that reporting year, and this is us acting as together as the corporate trustee. So the report contains, as normal, a resume of events during the year. The financial results were 78,000 raised in income, which is a slight increase on the previous year, by the way. £171,000 expended. That was a significant reduction on the previous year. There was a sort of dialing back of distribution of funds, and that position left the charity at the end of the period with £308,000 funds in total. Consistent with these kind of reports, there's quite a bit about the way the charity is governed, about delegated authorities, quite a bit on the policies, both in terms of reserves. We meet the reserves policy and the accounting treatment for the accounts. The accounts have been reviewed by an independent examiner who has nothing to bring to our attention as the corporate trustee. And in that vein, I've got nothing to bring to your attention from the committee about these accounts. So I'm asking you to approve these so that Pete on our behalf can sign them off and they can be lodged.
Thank you, Stuart. Mike?
Yeah, just a very small point of accuracy on the content sheet. It says report of the trustees, plural. That should be trustee singular.
Exactly. A little typo there. Yeah, thank you, Mike.
Thanks, Mike. Okay. As corporate trustee, are we happy to approve this paper to be submitted to the Charitable Commission? Thank you very much. Okay. Right then, moving on then to Quality Committee Assurance Report. Phil.
Yeah, we had a good meeting on the 14th of December with lots of positive assurance. We agreed the updated QPAS terms of reference. I have sort of reflected on sort of the trust journey from good to great, and I think I'd like the execs to think about when we're doing papers, putting up more focus on, so what does this mean for the patient? Some of the quality things that we get are all about meeting trust targets, which obviously are meant to provide good quality care, but I'd like it to be more explicit on the so what for the patient. And as I say, when we're in that journey towards great, everything we should do would be about improving the care for our care and safety for our patients. And then just some things to highlight. We talked about optimizing training for protected characteristics. We were asking EMT to note when looking at trust training plans. And we wanted to also to highlight the training of staff without professional qualifications and make sure that that's really got a priority. We noted the real importance of trauma-informed care, and we really, again, as we've done today, noted the how vibrant our quality improvement and research and development approaches are, and how being so progressive and proactive enriches people's professional experience and also enhances the reputation of the trust. That was really gratifying in the last meeting to see both QI and research and development being so vibrant in the trust. And I think that was everything.
Thank you, Phil. Any questions to Phil? No, thanks very much for that. And then we move on to the February Board Strategic Development draft agenda. When we met in December, one of the sort of feedbacks was about, not having too many items on the agenda. So Michelle, Stella and I, when we had a look at this, what we've actually tried to do is we did have what seemed more items, but actually some of the items actually were part of the same conversations. So we've tried to group it a little bit more, as you can see from the agenda. So it's one conversation that touches on a number of, I suppose, areas that feed into that rather than as separate items. So I hope that is a sort of better. So for example, budget reduction strategy update, actually having a discussion about planning productivity sort of aligns with that, I think, quite well. And I think so we're just trying to get the synergy between some of these areas to fit better together. And I think that will be really helpful, I hope, for our discussions at those meetings, which I think, yeah, another reflection back in December when we met was actually it's been really good that first year in 23 of this new way of meeting to discuss strategy. But any questions on the agenda for February? Great. Okay, lovely. Items to escalate. I haven't been given any notice of those. There's no any other urgent business on this for this agenda. Review of the meeting. Any comments on that? There's been a lot of discussion today. We've gone over my time, but I think it was worth it because I think the quality of input and questions has been really high. So my apologies, I should say, in terms of being humble to some of those people who came to present, that I gave them an earlier time than it actually happened at the end of all this. But I think it's great. I would just say also just to, you know, for in the chat box, there's lots of ideas and thoughts in the chat box. I've been trying to look at, you know, could everybody just have a, if you haven't had a chance to scroll through the chat box and have a look, because I think there's some other additional thoughts and comments that colleagues have made as well, which the appropriate individuals can to take away. But any comments from anybody else in terms of today's meeting?
So I think that, yeah, when I read all the reports in total, I feel they provided a really positive set of evidence. So we've got some things that we want to work on. We've got some external factors hard to control. But I think looking back on sort of previous meetings, this feels like real progress being made. I mean, really, I felt really encouraged reading that suite of reports and the answers we got when we said what's happening here. Again, I got the impression from both members of the board and visitors that people are on the case on things that I can see from the performance report, for example. So good stuff.
Thank you, Stuart. Thank you. I think, Dean, was that a thumbs up or it was a thumbs up? Okay. Anybody else? Any reflections?
I thought it was good. I thought it was good. Just some good
hang on, Michelle. Hang on. Let's take Phil. I'll come back to you. You can have the last word, Michelle. Phil?
Yeah. Particularly online, I think I have a short attention span, so I can easily get bored and lose a thread. But today's been a really interesting, engaging meeting that didn't give me a chance to get bored. And although it's run over, there was lots of really great reports, pertinent inputs, and I think it sort of demonstrates the real progress of the trust. So it was, it was really good.
Great, that's good to hear. Michelle?
Well, sorry, thanks for that. And a bit like you, Philip, I do have a slight attention span, but also patience as well. But I thought it was good. I know we've gone slightly over time, but I think not by much, Caroline, so very well done. I think for me, just reflecting back, though, onto our BAF and to our strategic objectives, I think when you look at the agenda, the conversations, it balances up. And obviously, Phil, you just summed it up very well earlier on. The number one thing for us is about patients and patient care and what we do. And I think that was all the way through. So thank you for that. I think it was really good. And great. Thanks to my colleagues and everybody on the board. It was good and well chaired, Caroline.
Thank you very much. So that's the bar that's been set for when we reconvene in March. I hope anybody who is looking in or maybe later on you'll be looking in and seeing this, I hope you found it useful as well, and some of the information was accessible to all of those viewers. So great. Thank you, everybody. I suggest we reconvene. It's 12:21. Let's have half an hour and come back at just after 10 to 1, and then we'll get cracking on part 2. Thanks, everybody. Thanks very much. Cheers.
Cheers.